Well, if you guys are all right with it, I think we're going to get started. My name's Norman. We're going to do some introductions here. This is Josh Minori. He's one of our heads. He's up in the Park City group, doing our pain management clinic up there. And then we have myself. I'm down in Provo in Spanish Fork. I've been doing this now for about 9 years, having previously practiced in New Mexico. This is Tom Selleck. Sorry. This is Dr. Romankowski, representing the Salt Lake Clinic. And we love Romankowski. He's done a great job for us. Used to be down in Provo, and then he moved on to Salt Lake, unfortunately. But we love him. And this is, is it Stephen? Yeah. Stephen Anderson, who's representing us from Bountiful and also working up in Ogden at McKD. We're going to be talking more, going through the core REMS, get through some of this, about why we're here. As many of you know, Utah, unfortunately, has been one of the leaders, and this is not where we want to lead. It used to be in opioid prescribing. As part of this, though, we're going to be doing the education requirements, and as many of you know, we just need 4. We're going to recognize the origins and types of pain as they relate to pain management and opioid use disorder. We're going to fully assess persons experiencing pain, including risk for opioid use disorder, develop safe and effective pain management plans using non-pharmacologic and pharmacological options, and partner with patients to reduce risks when taking opioid therapy. Right now, with the CDC data, they've let us know that as in 2025, the opioid deaths, mainly fentanyl, although about 37% of that is also related to prescription opioids, has now taken over from ages 18 to 45 as the main cause of death, eclipsing suicide and also eclipsing other forms, including COVID-19 and heart disease. Now, there's been 4 main waves. We're going to talk briefly about each one. Wave 1 was kind of the beginnings. This was the 1990s. This was the 5th vital sign and other things, as many of you may remember. Unfortunately, with prescription opioids, OxyContin, and other things that were becoming available, this started taking over, and we started to see a rise as we were prescribing opioids. It started to see a rise in opioid-related deaths. This went on through about 2010. Then we started to see another wave in 2010 as people started being wary of the opioid prescriptions. We started to see a rise in heroin. That has since been improving over the past couple or few years, and we hope to see a more eclipsing decline. But as that has gone down, we started to see more in wave 3, the synthetic opioids, mainly fentanyl. We're going to talk a little bit more about that, and particularly fentanyl analogs. This is your illegal fentanyl. This is the street where there was a big bust, as many of you may remember, in Salt Lake, where there were thousands and thousands of illegal fentanyl pills that were being created here in our locale. Mostly Chinese fentanyl and other that we're being concerned about. Fentanyl, as you know, is about 50 to 100 times stronger than morphine. With the illegal fentanyl analogs, we're starting to see even, it's hard to say, is it 134, is it 170? I had a patient who, when I asked him, he mentioned to me where he was getting his. He wouldn't tell me, but he said, I am getting it from the cartel, and he had to drive a distance for it. He took, at the time, he was taking about 2 to 3 milligram pills. Now, note, one pill is enough to cause a lethal dose. This is the main wave where we're mostly concerned about and really trying to law enforcement and others are trying to help us out with. But we're also seeing a wave 4 that's going a little bit further. This is not just fentanyl, but we're seeing xylazine. Has anyone been familiar with xylazine? Okay, it's a veterinary sedative. They often use it to help sedate cows, horses, and other animals. But they've been using it along with street drugs, including fentanyl, to try and help make it more toxic. We're going to get a little bit more into that, as well as kratom here in just a second. This is, unfortunately, as we've been seeing with the opioid prescribing, this has not led to a significant reduction in opioid-related mortality. Part of that, again, comes because of some of the fentanyl and other things that have been taking over the market. We used to think that this was more back east. This is more your Philadelphia. This is more New York. This is other areas. But we are seeing more and more of it come across here in Utah. And opioid prescriptions nationwide, we're seeing, unfortunately, fortunately a reduction in that, but still seeing a number of deaths that are occurring. This is important to note a little bit about our area. We're kind of a little bit of middle of the pack. We'll see some of the data here in a minute. In 2012, we were the fourth state, well, I should say the fourth highest state in opioid-related deaths. This was opioid prescription deaths. Right now, we used to be one of the highest prescribing behind Kentucky, New Mexico, and I believe it was Mississippi. But right now, we've been seeing some of those rates here in decline as people have become more aware and tried to make more efforts. You can actually see how, if you were to take a look at this, you can see what it is right now, more in our area. Again, this is some of the figures. In 2024, 2025, we started to see a little bit more of a decline in the opioid death rate. I believe in 2024, there was 617 deaths related to opioids. And in 2025, there's been about 601. So we're starting to see a slight decline. This is xylazine. I want to get briefly so you can see the pictures. This is being added to, as we mentioned, fentanyl and other analogs. This, unfortunately, not only does it cause hypotension, but skin ulcerations. And so if you see a patient with these, you've got to be concerned about it. I actually had a patient just the other day who was telling me their brother was starting to get into this as well, into these illegal, the adulterated substances along with it. So watch for this anytime ulcerations, any bradycardia. 97% of it is occurring along with fentanyl. The respiratory depression, unfortunately, is big with xylazine, and naloxone will not block it as it is not attaching to the opioid mu receptors. This is just briefly about where we're seeing it, region 8, but this is now kratom and 7-OH, 7-hydroxymitragine. Kratom is a natural occurring substance. This, unfortunately, is being marketed as a natural opioid. I had someone I knew who unfortunately got addicted to this. At low doses, you can use it as a stimulant as it's being sold over the counter. Higher doses, it can also help sometimes with pain. 7-hydroxymitragine is a natural compound that's found in kratom, but it's normally at lower doses. What they're doing now is making higher dose substances and concentrates in gummies and candy and other that are being marketed with this. Unfortunately, because of that, this can be not just highly toxic, but it's about 13 to 20 times more potent than morphine. It can also be cause severe respiratory depression. So they're trying to make more people aware of it. I've had multiple talks with patients about the importance of avoiding anything like this that's being seen in smoke shops or wherever, and the dangers of it. So we encourage people to, particularly with 7-OH products, yes?
I believe on Wednesday, the Utah Medical Association president said that they just passed a May 6th law against kratom.
Oh, wonderful. Wonderful. That is great to hear. Great to hear. I actually had to send someone to LDS Hospital to their addiction recovery because of this. And so years ago. And that's, again, just the 7-OH, because of this is just a reminder, more or less, because of its respiratory effect and how potent it is, showing there is an alarm. And this was I think these slides were made before that then, because of how alarming it is, the respiratory depression. Now, one thing to note, though, Kratom does bind to opioid mu receptors. It also binds to alpha adrenergic receptors. So naloxone can be helpful if you ever do suspect a kratom overdose. And we encourage if there's anyone ever, but it won't block everything because it's affecting other receptors, both in the brain and the body. It will help reduce the respiratory depression effect, but it may not necessarily stop the withdrawal effect and potential seizures, as well as, unfortunately, heart arrhythmias that may also occur. We're going to get into pain. There was a question. We'll talk more about it later on. And I believe Romankowski. Turn this one over to him.
Just press the green, Norm?
Yeah.
Okay. All right. I'm Matthew Romankowski, interventional pain. I'm at Salt Lake Clinic. Actually, Dr. Chris Mendoza is one of our partners there. Been practicing pain medicine. Got out of fellowship in 2019. Been practicing since that time. So trained as an anesthesiologist, but did a fellowship in pain medicine. So this is kind of bread and butter for me. I really focus on interventions. But today, some of the goals are to just give you a background of the pathophysiology of pain, or the understanding of what we know, how pain affects our body, and then come at the end of mine kind of talking about an exam or how we approach a pain patient, and then it goes into some other more detailed therapies. So this first part is the definitions and biology. Some of the learning objectives would be to differentiate the common etiologies, neural transmission and neuromodulation of pain, distinguish between acute and chronic pain, distinguish between nociceptive, nociplastic, and neuropathic pain, so the different types of pain, identify the body's homeostatic mechanisms for resolving pain, and then recognize the relationship between one's physical, psychosocial, and spiritual health, and one's experience of pain. Okay, so this is a newer slide this year, really talking about the timeline of pain, and how we've generally thought about it is there's the acute setting, which is usually less than about a month. Someone's experiencing this pain, and then we move into the subacute setting, which is usually about a month to 3 months. And then once we get past 3 months, we get into a chronic pain situation. And if you look at these two graphs, this would, on the left-hand side, this would be kind of the normal course of pain. So we have this nociceptive stimuli. Say, for instance, you get a cut on your hand, right? You have normal pain from that cut, normal transmission of that pain, and then you have predicted tissue recovery. So we would believe that the body is naturally going to heal itself, and with that, pain will decrease. So in a normal setting, you have that cut on your hand. It hurts for a while, but it gets better, but the cut's not fully healed. It's on its process of healing, but you've essentially gotten to a point where you're not in pain anymore and you are healing. So it's a normal pathway of us to be able to experience the pain in a healthy manner without it progressing to a chronic setting. So the graph on the right shows more of this chronic state. So we have more of this unregulated pain in the setting of tissue healing that's already occurred, but ongoing pain that has continued. And there's a number of different mechanisms as to why this happens, but this would be kind of setting into more of the healing and remodeling is ongoing because there's overuse, there's inflammation, there's central sensitization, and pain persists despite that tissue remodeling. And at the bottom there, really important definition here is the IASP would define pain as an unpleasant sensory and emotional experience associated with or resembling that with tissue damage. So there's an emotional component and also this physical component. You can't have pain without those two things happening. So different types of pain, there's a whole range of different types of pain that we experience throughout life, and it's really important to classify patients or try to understand what type of pain your patient is experiencing, because that helps direct care and therapy. And so a very basic, once again, the cut on a hand or finger on attack or a toe on attack, you're going to get this nociceptive inflammatory type pain. And its response to injury or stimuli is typically very acute. And so some examples of that are postoperative pain, arthritis, mechanical low back pain. There's actually, some mechanical issues with that back that are causing the pain. And then we transition, we'll skip the middle one, we'll go to neuropathic pain. This develops when the nervous system is damaged. Some examples of that, and there's absolutely no benefit to neuropathic pain, by the way. But some examples are postherpetic neuralgia, trigem neuralgia, neuropathic, low back pain, CRPS is in that category. And then there's mixed nociceptive neuropathic, but nociplastic is one that arises from altered nociception. And it typically becomes this chronic state. And some of those really difficult patients that you see in clinic, multiple areas of the body that have painful, subjective painful issues to them, would be those fibromyalgia patients. Irritable bowel kind of represents that same classification of patients. And then this nonspecific low back pain. You can't find any identifiable reason for them to have this back pain, but it occurs. And so this is more of that nociplastic. And it's a newer term that we use. And I think, if you're trying to define where your patient is on this spectrum, they may fall into that nociplastic if you can't kind of get into that neuropathic or a nociceptive type of pain. And then the mixed type, primary injury, secondary effects. We also have psychogenic pain, which is more so physical pain caused by increased or prolonged mental or emotional stressors. This is a real thing, but it's very difficult to identify those patients because there's no evidence of physical injury or harm. So it's unfortunate because a lot of people that don't get a formal diagnosis, could be written off by one provider or another and say it's psychogenic pain. But there is a definite classification of those patients, so I don't think it should be underlooked or overlooked. So the neuromechanism of pain. So this is kind of how we will walk through someone getting injured or how pain will transmit. So imagine Joey Bag of Donuts. He steps on a tack here, and that's that nociceptive pain, that initial stimuli that's developing. And so with that, you get transmission through mixed fiber neurons. So we have A delta, C fiber, and then A beta type of nerves, and those carry some of this painful stimuli. The A delta are thin myelinated. It's really for localization, where on the body did this happen. And then the C fibers are unmyelinated, and that's diffuse localization. So kind of in this body region, that information will be traveled along those fibers. And then the A beta are large myelinated, so they differentiate fine touch and proprioception. So that pain signal will travel along these nerves, and it'll get to the spinal cord where it'll synapse, and then it'll decussate and move up that spinal cord. And it'll move up that dorsal column to the thalamus and the midbrain. The periaqueductal gray, I think, comes in here. So we get some, up transmission, modulation can occur all through that region. And then up in the brain, we can also modulate some of those painful signals. But the periaqueductal gray, the limbic system, has components of the amygdala and the anterior cingulate gyrus. And so those are really kind of that emotional part of pain. Really important when we talk about how to address some of these issues with medications, and that'll be a little bit later discussed. But the thalamus knows kind of where that foot is as well. It helps with localization, and it'll send the information to the somatosensory cortex. And consciously, that's kind of where you have perception of pain. But all of these things together kind of function to have that emotional component along with that painful stimuli, so you're actually experiencing the pain. There are quite a few peripheral pain modulators. So we have on this left side histamines, prostaglandins, bradykinin, substance P. The TRPV1, that's where capsaicin actually inhibits that receptor. Sodium channels, that would be our local anesthetics that would block those. So these are ways that we can augment how that pain is materialized or experienced. And then the descending neurotransmitters, serotonin, norepinephrine, endogenous opiates like dynorphin and enkephalin and beta and endorphin. So a number of ways that we can augment, once again, with a descending transmission to block those pain signals going up that spinal column, that dorsal column. So opioid receptors, they're everywhere. The mu ones are what we're really interested in. And so we see kind of these triangles here all throughout the body in the GI tract. This is why we get constipation as one of those main, one of the main side effects of opioids. We have them scattered throughout our respiratory system, our peripheral nervous system, in that spinal cord, in the rex lamina, the substantia gelatinosa. It's really rex lamina, I think 2 and 5, that are the main opioid centers. And then up in the periaqueductal gray, the brain stem, the locus coeruleus, and the nucleus accumbens. What is substance use disorder? It says in here, open it up to the crowd. What do you guys think substance use disorder is? Anyone? Good. Well, it's an umbrella type of term. Really what we're looking at are, if you see on the right side here, this opioid use disorder, alcohol use disorder, cannabis use, combination of medications, those all kind of fall under the umbrella of a substance use disorder. And when we think about that, we have terms that we always come back to, and addiction is one of those terms. And the DSM-5 would say that continued use of drugs or activities despite knowledge of continued harm to oneself or others would classify this individual with addiction. It's treatable. It's a chronic medical disease. 85% of kids, adults, would not recognize addiction as a chronic illness. So anywhere from the age, I think it was like age of 12 up to 65, people were polled. And when they talk about addiction, it still has this very negative connotation to it, but it's also not recognized as a medical illness or a treatable disease. And that's unfortunate. So we need all of those in the medical community, and we need outreach, and we need education, really is the most important thing. Okay, the neurobiology and cycle of substance use disorder. So this is an interesting slide. I'll just get to here. I'll talk kind of how this develops, this substance use disorder, and it's pretty interesting. Let me get to my slide here. So all of these areas with the asterisk are opioid receptors, if you see here in the bottom. So every part of this region that's shown in the brain can have some effect from opioids. And so substance use disorder begins with binging and intoxication with the agent of addiction, prescription opioids, heroin, alcohol, cocaine, gambling, etc. The initial rewarding euphoric effect is mediated by increased dopaminergic tone in the limbic system. As the opioid use disorder progresses, a second stage of attempting to avoid withdrawal results in negative affect. The drug continues to be taken not for euphoria, but more so to stay away from withdrawal symptoms. As the disease becomes more established, preoccupation and craving become part of the clinical scenario. Function of the prefrontal cortex is impaired, leading to impulsive and compulsive drug taking, like a wheel turning. When in withdrawal, it pushes you to preoccupation, and then the drive will continue whether one is trying to put on the brakes or not. It becomes self-perpetuating. The opiate system, the cholinergic system, the dopaminergic, noradrenergic systems all mediate the changes to the brain as the cycle continues. So really, it's tough to start to change patterns. But when we listen to our patients, we can first need to figure out a diagnosis. Are you in this category of addiction? And if you are, then we need all of those individuals to have access to care that's going to help them break this cycle. Cocaine, site of dopaminergic and adrenergic effect in the nucleus accumbens. That's more that reward center there. So binge, intoxication, and it's this kind of cycle, this snowball effect. And it just keeps going around and around. Opioid use disorder, the DSM-5 criteria, very important. So be alert to these factors in your patients on long-term opioid therapy. So, are they taking larger amounts for longer periods than intended? Is there persistent desire or inability to cut down or control the use of this medication? Increased time spent obtaining, using, or recovering. craving, compulsion to use opioids, having issues at home, at work, at school, social or interpersonal problems, reducing the times that they're going out and being social or active, physical hazards like injuries, and then physical or psychological harm. So a number of criteria that need to be present for each kind of degree of opioid use disorder. So 2 to 3 of these would be mild, 4 to 5 would be moderate, and greater than 6 is severe. And it says here tolerance and withdrawal, not part of that criteria if people are taking opioids as prescribed, because people can become tolerant and can have withdrawals naturally when on an opioid that's being taken appropriately. And that's one of the unfortunate things about opioids. There's increasing dosages needed to meet that same threshold of relief. And they will physically have withdrawal if you stop them on that medication. Go ahead.
I have a chronic pain patient who's taking opiates for chronic pain,
Uh-huh.
but they're not binging and they're not, having those kind of things. Is it still considered an opiate use disorder?
No, I would not consider them on that spectrum. I would say that if they're taking their medications appropriately, if you're documenting that they're meeting some criteria of increased benefit of their ADLs, of pain reduction, and there's no aberrancies that you've noticed, if you're doing your drug screens, they've signed their MMA, then these are things that you just want to be looking for, because it can progress to that. And I don't know the specific number of progression. Norm probably does. 5%. So 5% will progress. And that's on just a single agent. So if you add a benzodiazepine or other agents, that can change as well. Okay? But very good question. I mean, because a lot of us have patients on opioids. And, what's the switch? What's the inciting event that puts them to that next step? Could be a lot of things. Could be an emotional stressor, some sort of other painful issue that develops that sets them on that pathway. So being very vigilant is important. Okay, so we talked a little bit about the biology or the pathophysiology, and now this is the evaluation of that patient with pain. And so we want to be intentional and avoid stigma. Pain does come with a stigma, as well as how we talk about it. So we want to change the language around this. So being a provider and having a patient come in, you want to be empathetic, compassionate, and say statements like this: is it okay if I ask you about alcohol or drugs? Don't just immediately assume your patient's okay with talking about that. There can be cultural differences, spiritual differences that makes that conversation a little bit more challenging to approach. But if we approach it in a very open-minded way, then I think we can get a lot of information from that. So some terms to avoid would be addiction, because it comes with that stigma. So some preferred terms are substance use disorder or opioid use disorder. Drug seeking or aberrant behavior. You're not using your medication as we prescribed it. We really need to talk about this. An addict or a user, very, very tough. Patients will come in and say that, that even their pharmacist labeled them as an addict or a user when they're using their medications appropriately. Say you're changing an opioid. I had a patient just the other day doing everything very appropriately. She's on a buprenorphine product. She's gone from one pharmacy to another and been labeled by numerous pharmacists that she's an addict or she's aberrantly using these medications when she is not. And so I've had to call pharmacies and talk to pharmacists directly. And it comes with a huge emotional toll on that patient. And so now she's fearful of going to any pharmacy just because she doesn't want to be labeled an addict when she's using it appropriately. So that in and of itself can be a really terrible term when we're talking about our patients and what they're dealing with. So dirty urine, failing a drug test. You've tested positive on a urine drug screen. You don't have to go saying that it's dirty. It's a clean urine. Go ahead.
Can I use the microphone?
Sorry. Little. Sure. Sorry. Can you hear this? Okay. If I'm here, not so far away. Okay. Yeah, you don't have to say it's dirty. You're looking for certain things, and if it comes up positive for those things, mention that it's positive. Abuse or habit, I don't know. You can say abuse. I wouldn't say it's kind of goes with you're using your medication as not prescribed, but you're using it other than prescribed is how you can go about it a little bit better. And then substance abuse, more like substance use. Big X through there. Okay, once again, be intentional, avoid the stigma. So use person first language, try to normalize care. They're not the only person going through this or using medications that are somewhat stigmatized. So let's normalize this. Recognize that you have your own personal bias and try to eliminate that as best as you can. And then, peer influences. I would say, you guys are here learning about opioids. You have a much better education than someone just on the street, and I think you can be that influence to others on how we talk about this and how we treat our patients. So now, the biopsychosocial model, we learn that in med school, and it goes throughout our career. But we know that all these organ systems and parts of our lives interact with one another. So. Any type of social changes, family, intimacy, work, psychological changes, depression, anxiety, as a big one here when we talk about pain, and then biological changes of inflammation, fatigue, sleep, nutritional status. All these kind of affect our function, and so it's hard to kind of just take little pieces of the pie out. We want to look at this as holistically as possible. And I think the more time you have with your patients, which is very hard for all of us, the more we get to learn these different aspects about our patients' lives that can really help us treat them more holistically. So if you see that pain patient, you're going to start with some pre-screeners. A lot of us have those already kind of built into our new patient paperwork, like a PHQ-9 or 2, and then the BPI. I do an ODI. I do a Promise 10. So these are just some ideas of like global mental health, global physical health, and then we get into the patient talking about their pain. We use some descriptors. Old carts is a very common thing for us to use, but really, where's the location? How intense is it? What type of quality is it? And that'll help us, that quality one, help us determine, maybe we're in that nociplastic, neuropathic, nociceptive. We can categorize a little bit better, and that then helps us in the end, exacerbated or alleviated by these type of things. And that also helps us delineate between different pathologies. And then the level of pain and its effect on their life. How is this affecting ADLs, the activities of daily living? I think it's really important that we think of function a lot when we talk about a pain patient, because people can be in a lot of pain but still be very, very functional, and vice versa. They can be in minimal amounts of pain but be very non-functional because of the pathology that they're dealing with. So I think figuring out where you are on that spectrum is really important. Relevant illnesses, cancer, diabetes, any restrictive lung diseases, cardiac issues. These can all affect how this person experiences pain. So really doing a thorough evaluation of the comorbidities. Some non-pharmacologic strategies and effectiveness. Have you done PTs? Have you done acupuncture, chiropractic care? Because different pain syndromes can be really well managed with some non-pharmacologic therapies. And I think if we leave that part out and go straight to medications or straight to injections, which I love to do, we're missing a whole other aspect. And I think Dr. Minori will go a little bit more into that. But pharmacologic strategies, we've got to know, what have you used? What's been effective, what has not been effective, and are you on an opioid? Because if this patient comes to you on an opioid, you're going to want to query your state's PDMP. You can get a lot of information about how someone tells you about their medication that they're taking versus the objective data that we have, especially from the PDMP. Now, Utah is one of the states that does provide a PDMP, or the Controlled Substance Database. There's 52 others throughout the nation. Some don't report to other states, but Utah is one of those that does report to other states, so we're in luck here. But if someone's on concerning medications, especially like an opioid and a benzodiazepine, you might want to talk to the previous clinician or whoever's prescribing now, and they're attempting to have you overtake medications. You want as much history as you can get. You know, you want to know if there's been any aberrancies within clinic, because our notes sometimes don't share that. Maybe that's, you know, personal preference to not put that in your patient's note, or, you know, it's in a note, but it wasn't carried over and it's just not something you've thought about or that prior clinicians thought about, but you want to know it. I mean, you want to know what you're getting into. And so it's really important to know who they're being prescribed by, and the PDMP will give you that data as well. If a person comes in and does not remember who their provider is, which I have quite frequently seen, querying the database and kind of getting a hold of that other clinic's really important. So. And then you want to determine if they're on that opioid, are they tolerant to that opioid, or are they in some process of pseudo-addiction where their pain is undermanaged, but they're taking it appropriately, or are they not really a good candidate for ongoing opioid therapy, and are there other strategies that have been missed? So what are some of the barriers to previous treatment strategies? This one is more so financial, you know, maybe even rides to the clinic or the pharmacy. So what does that patient's look like? What does that life look like outside of them seeing you in clinic? So a non-punitive approach to prescribing analgesic agents. So once again, confirm the PDMP information. Identify drugs that increase overdose risk when taken together. That's one big one in particular. I mean, Norm just went into it, but any opioid with a benzodiazepine is a significant increased risk, and it's not a linear relationship there. It's a dose dependent, can rise very quickly. So be on the lookout for that. Our PDMP also shares that information with you, and they will put little markers there that show risk level when you're looking at it. And checking the PDMP also lowers the rates of prescription opioid-related hospitalizations and ED visits. So multiple prescriptions from different clinicians. You're looking at maybe some aberrant use there, and it warrants some more workup. And then once again, you know, our PDMP, it's really big. I check it on every patient every time they come in. The requirements in Utah are not to do that, but I think it's really important, especially if your patient's on a controlled substance, for you to have that medical legal coverage that you have checked, and you're looking out for your patient's best interests and your medical license as well. So they're entered. So reporting of this, the PDMP is entered on a daily basis. I have seen some pharmacy, it take a little bit longer to get into the system, but inevitably it'll show up. So I don't know if that's like the system itself, the computer system itself, but they're required to report on a daily basis. Go ahead.
One caveat to that is if they feel like at Hill Air Force Base or through the VA, it will not show up on the PDMP. So you do have
There you
to
go.
call in for that to the VA specifically to get that information. So.
Good. And like I said, Utah does share its data with other states, so it's really important for other states to know, and especially if your patient's going out of state, you can notify them of that. Out-of-state pharmacies aren't required to report to the patient's home state, but speaking with your patient, hopefully you can get that information and get it very clearly understood and into your medical record. Patients will be notified when the record has been accessed, so it can't be willy-nilly going after it. And then a complete psychosocial history. You're going to want to screen for mental health issues, depression and anxiety. There's a direct correlation between increased pain and those diseases. And so if we're not adequately managing one or the other, then we could have worsening depression and anxiety because of the pain, or worsening pain because of the depression and anxiety. They're positive predictors of chronic pain. And then look for alcohol, tobacco, other drug use, history of adverse child experiences. And we'll talk about that, I think, on the next slide. And then any family history of substance use or psychiatric disorders. Some of the social determinants of health are related to pain through built environment, economic status, education, healthcare access, and social support. So when you're talking to your patient, be aware of kind of their background and what they've been through. So adverse childhood experiences, we call these ACEs. Actually, one instance of ACE will increase your likelihood of having chronic pain by 60 to 170%. So a very big range there. But these are, what has this patient been through in their life? So it increases some of the things like central sensitization, stress sensitization, HPA activation, and allostatic load. Some of the psychological risks of having an adverse childhood event is, catastrophizing when we're talking about how they manage their pain. When we catastrophize, you make everything a little bit worse. And so talking about pain becomes a very stressful deal for them. And so utilizing our psychologists and our psychiatrists within the community can help kind of work through some of these ways that patient experiences pain and talks about pain. Some psychological issues, we already talked about anxiety and depression, and then some social risks, how do they cope and what are their peer social resources? So opioid use disorder is particularly predicted by ACE severity and frequency and type of ACE. So it does depend on the adverse childhood event, but for the most part, like abuse, neglect, parental substance use, those all kind of correlate to this potential chronic pain and potential opioid use disorder. So then we want to go into a physical exam. I don't want to leave without a physical exam. And you're going through, I do a lot of back pain stuff. So with my physical exam, it's very directed towards spine. And so each patient that comes in, obviously, there's going to be maybe a different location of their pain. And so the physical exam might look a little different. And we gain a lot from physical exams. I'm a big believer in having your hands on a patient and moving them around and utilizing some of the exams that do have some data to support them. But it's not the whole clinical picture. I think it's a piece of the pie. And when we look at a patient, we look at them as holistically as possible, because some imaging studies might show horrendous pathology, say in the lumbar spine, and the patient's not really in that much pain, and vice versa. They might be in a significant amount of pain, but their imaging or their physical exam wouldn't lead you to believe that that's why, basically. So that makes it a more holistic. You need this well-rounded approach to the assessment of your patient. And that's kind of it for me. I don't know if anyone has any questions about what I spoke about, but we'll lend it over to Dr. Minori. Modulate the systems that I can. So sometimes that's medications, sometimes that's interventions, sometimes that's refreshers in physical therapy, acupuncturists, kind of going down a more integrated medicine route to see if there's anything I can do. So those are tough patients. So I don't have the best answer, because who knows sometimes, but go ahead, Norm.
Yeah, can I add briefly to that? I like what Matt. Really quick to add to that. With some of these patients, I had one a while back where they were there for their neck and the headaches, but just touching on it they started flinching. And so then I started pondering, asking a little more in-depth questions, asking about fatigue, asking about difficulty sleeping, signs of nociplastic pain. As we went a little further, I did the 12, some of the old standard 12 points or 18 fibromyalgia tender points, and really found that he was experiencing some central sensitization effect. And patients with fibro or nociplastic pain still can have neck and low back and discogenic and other pathology. So I will talk with them about that, but they may feel it more due to that hyperalgesia effect. And so it's important to address some of that. We actually will utilize a fibromyalgia program and other techniques to try and help desensitize some of that pain, focusing also on sleep management to help with that. And then we start addressing some of their back pain issues, and that may incorporate other interventional procedures as well. But the fact is, nociplastic pain can indeed flare up other types of pain, or they may feel it more. So trying to get a feel, that physical exam is important, and as Matt mentioned about that. So.
How's everybody doing? Hi, I'm Josh. I just want to make sure we're at a point where if anybody needs to take a break, or just we can do it now, or we can just wait till I get through this chapter and do it then. So we'll check in again after. That's okay. Is this working all right too? Okay, good. So I'm Josh. Background is in PM&R, and then I did a fellowship in pain medicine. I joined Intermountain Health in 2020. the day, April 1st, 2020. So it took me a few years to start to see some patients' faces, because we stepped in with masks on at that time. But I'm up at Park City in Heber is my location. So with this chapter, creating the pain treatment plan, there is going to be a lot of overlap in some of these slides with some of the information you heard from Dr. Romankowski, but I don't think it hurts to hear things a couple times. Our main learning objective here is really to try to develop a safe and effective pain management plan. So looking at non-pharmacological and pharmacological options. We really want to create an individualized treatment plan, including functional goals. We want to have evidence-based, non-pharmacologic, and non-opioid approaches. We really want to align the treatment approaches to a specific type of pain, which you heard from Dr. Romankowski. We want to consider opioid uses in special populations, so we'll go through a lot of different populations of patients. We want to look at identify common adverse events, drug interactions with opioid use, and really characterize the influence of the choice of a specific opioid. So it's really important with chronic pain that it must be managed. It's not necessarily resolved. So just kind of keep that in mind. So kind of looking at this slide, this really demonstrates a multimodal treatment plan that should be developed and should be customized to the needs of every patient. The goals of treatment should be based on expected outcomes. Obviously, pain reduction is what we're kind of shooting for, but also improvement in functional outcomes impaired by pain. So activities of daily living, quality of life. Every office I stepped into when I first joined had the pain scale from 1 to 10, and I just kind of took those all down in day one, because it's really about developing with functional gains, quality of life. That's what we're kind of looking for. And then, consider first using non-pharmacologic and or non-opioid therapies. So regardless of the type of pain, non-pharmacological approaches should always be considered. These approaches have been found to be effective alone, or also I prefer as part of a comprehensive pain management plan, particularly for musculoskeletal conditions and chronic pain. Some may be more applicable, obviously, for some conditions than others, but these options listed here are all worthy of consideration, and they do have evidence to support their efficacy. So I'm just going to kind of go through this. There's a few sections with this slide. And so this is a slide that was kind of discussed earlier with Dr. Romankowski, but we're kind of look at some treatment options here. I just want to point out that the medications that are listed here are in alphabetical order. There's no implied preference or order that they should be used in. And you can kind of read through some of those there. I want to touch a little bit, also just reinforce some of these definitions because they are a little confusing. Basically, with options for nociceptive or inflammatory, you can read all those. I also want to throw out there topical pain medications. I know we always kind of throw that out, over-the-counter topicals, but there are a lot of compounding pharmacies around. You just have to be aware of the costs. So calling around, finding the correct cost. But with a compounding medication, it can treat different types of pain with a combination of medication. And you can really tailor those to the individual needs of patients. So things like joint pain, and where there's not a lot of tissue to get through, they can really make differences. In even neuropathic pain, we've tried for certain things, and it's done pretty well. So just keep that in mind. They're low-hanging fruit there. And then neuropathic pain, this is where I think Dr. Romankowski kind of led into that there are a lot of interventional strategies that can treat the pain both centrally and peripherally. So just keep that in mind with neuropathic pain. If patient hasn't been evaluated by an interventional pain physician, that might be a good idea to see if there are any strategies there. The nociplastic pain, this is always kind of a tough one for me, but it's really pain that arises from altered nociception, despite no clear evidence of actual or threatened tissue damage or evidence of disease. So it is really multifocal. It's widespread. It augments the central nervous system. So pain and sensory processing is all augmented. You have altered pain modulators. You get an amplified pain signal, expansion of the receptor fields. You have decreased descending modulation of pain. So it can be really difficult. So I think he touched on before, particularly with this type of pain, you really should try to stay away for opioids if you are looking towards this type of pain. Example, a patient with fibromyalgia, they have just overall reduced mu receptor availability within the region of the brain that normally processes and dampens pain. So a lot of these pain signals. So a lot of these patients can, have these just lowered centers, and opioids are not going to really provide much benefit, and you have all the risk associated with little benefit. So this is just a few slides jumping in, just skimming the surface on cannabis, pain, and opioids. A lot of people are familiar with cannabinoid receptors. We have the CB1 receptor in brain and spinal cord. This mitigates sensitization and inflammation. We have CB2, brain, spinal cord, and at the DRG, which can reduce inflammatory hyperalgesia, so increased pain from chronic inflammation. With cannabis treatment of pain, it does demonstrate some mixed results. There is emerging evidence to suggest that cannabis may reduce opioid morphine equivalents in chronic pain, but there is an unclear impact on the adverse effects when you take them together still. So opioid sparing theory versus data. So theory, yes, if cannabis products can treat pain, patients can use these products to reduce their opioid use. The data there is, I'm just gonna say, kind of mixed. And if you read through these, you'll see within the first two. The states with medical cannabis have modestly lowered rates of opioid prescribing and risky opioid prescribing, but there are a few studies here, like in 2019, the association between medical cannabis and reduced opioid mortality has reversed over time. In 2021, opioid sparing effects remain kind of uncertain due to low evidence. And then in the 2022 meta-analysis at the bottom there, preclinical observational studies show some opioid sparing effect, but there really aren't any high quality RCTs yet that support it. So just jumping in, I think a lot of you already know on this slide here, within Utah, we have for medical but not recreational. There is some information regarding just kind of high CBD, low THC products that can produce a mental and physical relaxation. It can reduce excitability and really have kind of minimum to no changes in cognitive effect, looking at it that way. So really with this slide, before prescribing, we all should take time to understand the characteristics and take these characteristics into consideration. The FDA has compiled prescribing information for all opioids. It's a website shown up here. It's kind of an important point on this slide that you can go to the website and get all the information that you need for all opioids. It's also really important to keep in mind patients with other medical comorbidities, specifically hepatic or renal issues. They may definitely need a reduction in strength and dose to start with. And then this is kind of a newer slide here, really talking about the importance of shared decision-making. There's this kind of nice acronym here, and I'll just kind of go through it briefly, but S for seek your patient's participation. So encourage your patient to become involved in the conversation. That just may take a lot of time, multiple visits, and there's different strategies. We each create our own relationships with our patients to find ins, so whatever you can do there. Help your patients explore and compare treatment options, right, and ensure patient is fully informed on those options. Assess your patient's values and what their preferences are. Reach a decision for your patient using a collaborative decision making, and then evaluate your patient's decision. That's our clinical evaluation from the plan from a medical standpoint, and that's our job there. So just kind of moving on here, these are recommendations for when to maybe consider an opioid, and they're completely in line with the CDC guidelines. So consider all pain management options and prescribe opioids only when non-opioids are inadequate or when the benefits of using an opioid may expect to outweigh the risks. You can kind of coin it however you like, sometimes using a little terminology like we're going to have a therapeutic trial, where you're kind of building in expectations and understanding that if we try this medication for a short while and it's not working or doesn't provide the benefit we want, we are going to stop it. And what does work mean? Decreasing pain, going from a 5 to a 3. I prefer really determining the patient's goals and having that in your note, listing that from day one, that carries over. You're using this medication to achieve what? What do we want from this? Not just to reduce pain, although that's kind of also part of it. And then really like functional gains I mentioned earlier, quality of life, activities of daily living. Give specific examples. I ask patients, just give me 1 or 2 specific examples take time to develop that, and then I refer to it as treatment goes on. We just come back and circle back to those goals, and they may change, but it also gives patients a lot of aha moments to say, look, I'm meeting some of these, I'm doing well, instead of just, my pain goes from a 5 to a 3, which changes probably every 30 minutes. So it's vital to fully consider the risks of using opioids prior to initiating treatment. So this goes back to the question I think you had, where there was a systematic review, meta-analysis, I think 12 studies, looking at the incidence of new cases of opioid use disorder. So actually medically diagnosed, not misuse or overuse, after treatment of prescribed opioid analgesic, and it was about 4.7%, so right around 5. There are people definitely who benefit from opioids. So they are effective analgesics for acute severe pain, post-surgical pain, patients who are unable to take non-opioid analgesics. They can relieve suffering, especially at the end of life, and they can improve some function for certain conditions. Let's see, this is that order here. Sorry. I think they skipped a slide here. Let me go back and see if I missed one. Oop. All right, we're gonna just, maybe it was taken out. We can get back to it in a little bit. It was, if it doesn't come up by the end, I'll just read the information because I think it's important. It was just based on the 2022 CDC guidelines, so it may pop up a little later. But we'll jump into this first. So options to assess risk for opioid use disorder. Dr. Romankowski touched on this a little bit. This slide identifies some options or tools to assess risk. Before using these, it's important to establish kind of a safe environment with your patient because some of the questions can be a little touchy for patients. So I usually tell patients that we have resources to keep them safe. The questions are for the purpose of providing those resources and treatments to help. All screening questions do have limitations though, so all of these have limitations, and there's not one screening instrument that can reliably predict those patients who are not suitable for opioid therapy. So really, presently, like a combination of strategies is recommended to stratify risk, to identify and understand aberrant drug behavior and tailor treatment accordingly for patients. So this just jumps in and looks a little more closely at the ORT. So that's the opioid risk toll for opioid use disorder. It's a brief 9-question measure to classify patients as high or low risk for misusing opioids prescribed for pain. Substance use disorder, so a history of substance use disorder does not prohibit treatment of opioids, but may require additional monitoring and expert consultation or referral, so just keep that in mind. There is a QR code, I think, at the bottom, but it might be covered up there. We can try to get you that information. That has a link and demonstrates a risk stratification interview with a patient, so it's kind of nice to kind of jump in and watch that on your own time if you can. So categories for opioids. This is a list of all the opioids that fall under into which category. I'm not going to go through and read them all individually here. You can just take a quick overlook. But I do want to bring some attention. In 2025, they did a review on tramadol, and there was potential harms associated with tramadol used for pain management may likely outweigh some of the limited benefits. So I just wanted to bring that to everyone's attention. So with this slide here, I want you to know items on the left, obviously, if you can read there on the top there, kind of the known common side effects there. And then on the right side, we have the opioid adverse events there on the right. And opioid analgesic medications, they do carry risk. Really, we know that, not present with non-opioid analgesics. Specifically, risk of misuse, addiction, they can lead to respiratory depression, overdose, and death. Opioid-induced, it's blinking, so constipation. It's one of the most common side effects. So just be aware of that. Make sure you do initiate for this. Put into place just some mitigation strategies, so whatever you prefer, stool softeners, increase a lot of fluids. And then it's our responsibility, really, to be knowledgeable about how to weigh these risks before prescribing opioids and about how to properly manage these patients who are prescribed opioids, both short and potentially long-term. So it's really important just to have a good understanding of these adverse events and these potential side effects, just to be aware of them and be able to pick them up. I sometimes have something like this printed out in my office, so just sits there and look at it every once in a while. So the big one here, opioid-induced respiratory depression. This is the number one most life-threatening situation with opioids. It is more likely to occur in older population. Also with other medications that depress your respiratory rate, benzodiazepine, muscle relaxers. Also patients who are opioid naive or anyone that you may be increasing a dose. So any of those transition points are really important times to really be aware, monitor the patient, have closer follow-up with them. And then conditions causing, if someone comes in with, obstructive sleep apnea, you definitely want to be aware of that because they're at a higher risk there. Again, how to reduce risk, don't overestimate the dose. So you can always go up. It's hard to, get to come back down without having the effects of too high of a dose to start with. Avoid co-prescribing benzodiazepines, and then make sure that every patient or caregiver has access to or is given a prescription for naloxone. Again, greatest risk is when combined with benzos. So naloxone is an option here. Naloxone, brand name, Narcan, it's an opioid antagonist, reverses acute opioid-induced respiratory depression. There's some videos up here on how to administer it, both nasal and the injectable form. It really works by displacing the opioid from the receptor. So just be aware too with this that it reverses the analgesic, so they will go into withdrawal from the opioid as well. It's most commonly sprayed in the nares, but can be given, like I said, intravenously, intramuscularly, and subcutaneously. There is mention here, you see it in the literature, for specific situations that call for naloxone co-prescribing, but I think as our group, we strongly recommend that, co-prescribing naloxone with any opioid prescription is probably in your best interest. So just some naloxone regulation for Utah. With this slide, I just want to kind of define some of these terms quickly here. So everybody's probably aware of this, but criminal immunity, it just protects medical professionals from liability for prescribing or dispensing naloxone, as well as lay people for administering it when needed. Third party, obviously, is a person not at risk for overdose, so these would be like family members, bystanders. And then a standing order, it's just a physician order that can be carried out by other healthcare workers when predetermined conditions have been met. So this is definitely a list to be very familiar with. These are signs of accidental opioid poisoning. The big question always comes up whether to call 911 or administer naloxone first, but it's an impossible question to answer. It really depends on your setting. It's not a one-size-fits-all. It is context dependent. So just assessing the situation first, 911 or administer both at the same time, if you're depending on the situation, if you can, optimally. But interesting little fact, this was a period of time from 2025 to 2018, 47%, I believe, of all fatal poisonings of US toddlers over that 14-year period involved opioids. So next slide here, just, we all know pharmacokinetics, just the movement of drugs through the body. Pharmacodynamics is just our body's biological response to those drugs. I want to bring your attention a little bit back again to tramadol. We just have to be careful with serotonin syndrome with this. Tramadol is a combination of a mu agonist and an SSRI. So when combined with other medications too, MAOIs, you could have a risk for serotonin syndrome. So just be aware of that. Also, some medications too at the bottom here can prolong QTC. We see that with methadone. So sure, you're just periodically checking EKGs, but a lot of us aren't really, maybe not prescribing or managing methadone as much for opioid use disorder. So a slide again just reiterates the importance of knowing the product-specific information before you prescribe. Consider the effects other medications patients are taking always here. And then just with transdermal, transmucosal drug forms, there's a lot more products that come in those forms, buprenorphine, one of those. These are just some special considerations with these delivery methods. Obviously, don't crush them, don't chew them, don't swallow either form, that's important. Note that there's an increased dose exposure with temperature. So patients with a patch on who may go into a hot tub or a sauna or even heating packs placed over that, be aware of that, make sure you let them know. Sometimes the metal foil on the backing might not be safe for MRI use. And then also rotating is very important. I mean, especially with the buprenorphine patch, there's a nice little picture diagram you can find on images or even through their website on how to rotate it. I really advise patients not to keep the patch in the same spot over and over and over again. Sometimes skin irritation I've had, yeah, Norm, you can go too.
It really is due to skin irritation.
Yeah. If you've, yeah, I've had a few.
And with Butrans patches, you really want to, I'll tell patients, you want to move it around, upper back, upper chest,
Yeah, there's
and deltoids, you know.
There's
that'll-
same spots, you have double, left and right. So you got a lot of options to rotate through. Some spots, obviously, depending on body habitus, for some people aren't great. We sometimes consider things, Tegaderm, use things like that over the top for if showering and stuff like that. But just find out what works for your patient, but try to avoid just the one spot only if you can. Even if it is just one spot, you have two, because you have one on the left and one on the right, so you can rotate through there as well. So with this slide, this goes into a lot of different populations, and I just want to kind of touch briefly on a lot of these special populations. So we'll start with sleep disorders. Please don't consider an opioid as a sleep aid medication. Just be very cautious with obstructive sleep apnea patients. About 2/3 of patients who experience chronic pain, obviously we know this, report poor, non-refreshing sleep due to a mutually kind of reinforcing relationship between the two conditions. The problem with pain and sleep is complicated because opioids can fragment sleep or break up sleep cycle. So if a patient experiences poor sleep due to pain one night, they're much more likely to experience more pain the next night, and so on, creates this just very vicious cycle. So we're going to just bounce around a little bit here. I'm going to just, with dementia, nonverbal patients, we'll go in order, actually. Patients should be evaluated still, should do an evaluation, but it may be less reliable. So just anticipate pain a little bit more. If someone has dementia, maybe it manifests as like a behavioral change or agitation. Talking to family members is really, really important. With obesity too, it's important to remember, I know that, when I was in medical school and we were going through orthopedics, you want to drop weight because it takes more pressure off your joints. But it's a lot more than that. Some of the increased levels of interleukin, like IL-6, which is a pro-inflammatory mediator, is held in adipose tissue. So it's kind of like, I sometimes say, if we have more adipose, we have more pro-inflammatory mediators. So if we do create an acute inflammatory effect, we're going to release a lot more pro-inflammatory mediators, and your pain level may be slightly higher. I also like to look at kind of mechanics as well, not just more pressure on a joint, but the spine itself. The spine was designed beautifully with certain curvatures in it to create sagittal balance, amongst other parts of our head-neck function and below the waist. But that can change with body habitus. And over time, if that sagittal balance is off, other structures in the spine are going to get more forces placed on them and could lead to more deterioration. I kind of think about this like if a woman becomes pregnant, the belly's a lot further out, so they have to maintain sagittal balance, or they're it's hard to walk and fall over. And the spine beautifully does that to kind of keep us upright. But if that was to go on for years and years and years, there's certain structures in the spine or certain levels that may degenerate or get more pressure on them. So I kind of talk through a lot of this stuff as well with patients. And then renal hepatic impairment, really, really important. Active toxic metabolites of many opioids are renally excreted. Accumulation can come in renal failure, so it can lead to an adverse event even when taking as prescribed.
How about the geriatric population? Because,
Yeah.
we have a lot of patients that get notes from their insurance company that they're over a certain age, they should be on this medicine.
Yeah, I get that all the time. I'm going to talk a little bit more about that population too, just kind of how to mitigate some of the risk associated with it. But I think, I tend to talk to those patients a little bit more, or not those patients, but if I get those letters and tell them, what I'm monitoring, what I'm looking out for, and they go, oh, okay, then you're kind of doing your due diligence in a way. But I don't think it's just a black and white on and off. You're over this age, so no opioids. I personally don't agree with that. Yeah, but great question, because it comes up more and more frequently, I feel like. So, like psychiatric substance use disorder, Psychiatric conditions and pain management issues are kind of comorbid conditions. They go hand in hand together. Prescribers, you need to be aware of drug interactions and development of potential serotonin syndrome. So I kind of work very closely with our psychologists across the street when we have patients together, even if we're performing certain interventional strategies, certain medications we may use for interventional strategies. If they have bipolar disorder, it could go into manic phase. So it's really important to be aware of that if you're kind of treating patients with psychiatric conditions, SSRIs, SNRIs, tricyclic antidepressants, just be aware of those medications. And then an end-of-life population. Really involvement in hospice, palliative care medicine specialists should be considered early on, I believe, with that population. So other special populations, older adults. It's just the complexity of managing the care of older patients with persistent pain does, I believe, call for a multidisciplinary approach. It's very, very, very important. Older patients have medical problems that can increase the risk of opioid-related adverse events. Respiratory depression is more likely in older cachectic and debilitated patients who may also have altered pharmacokinetics due to poor fat stores, muscle wasting, altered clearance in these patients. They're more likely to develop constipation, so you must routinely initiate and have a bowel regimen. And it's really important just to monitor polypharmacy in this patient population. Sometimes they're on many different types of medications for many different comorbidities, and then fall risk, cognitive changes, psychological state. So as long as you're kind of talking through those things with your patients and doing good documentation, I think you can still appropriately prescribe and make sure that they have support too. So other populations, pediatric, I'm gonna see if there's more here before it cuts me off. There we go, we'll just get everything up. So the American Association of Pediatrics released somewhat new guidelines in 2024 on opioid prescribing for acute pain management in children and adolescents in the outpatient setting, so not inpatient. And really, their guideline really said, do not prescribe opioid monotherapy for acute pain, avoid codeine and tramadol in many situations. So the safety and efficacy for most opioids in pediatric patients below the age of 18 has not been well established. And most of these agents are not indicated for pediatric patients. There were a lot of non-clinical studies examining opioid use in children and focusing on safe use, but that was in an inpatient setting as opposed to an outpatient setting. Pediatric indications for chronic pain opioid use is really primary life-limiting conditions. Relatively few pediatric patients with chronic pain due to non-life-limiting conditions should receive long-term opioid therapy. So another population here to take into consideration is kind of women childbearing potential. The American College of Obstetricians and Gynecologists for women taking opioids daily, they recommend buprenorphine or methadone. They also recommend universal drug screening for substance use as part of the obstetric care, and it should be done really at the first prenatal visit. Potential risks during pregnancy to the newborn include low birth weight, premature birth, hypoxic ischemic brain injury, neonatal death, prolonged QT syndrome, and neonatal opioid withdrawal syndrome. And opioid withdrawal can be expected into up to half newborns from opioid-dependent mothers. So just kind of more special populations, but more substance opioid use disorder. Patients with coexisting pain and opioid use disorder, like we all know, that they can be the most challenging patients that we may encounter. So it's really important to consider, again, a multimodal pain program. That is difficult depending on where you practice and the resources you have available to you. We are, like Dr. Romankowski mentioned, somewhat fortunate that we work closely with pain psychologists, we have behavioral health specialists, we work with clinical pharmacists, so we really try to develop a team approach, but it can be difficult at times, for sure. Enlist family members, caregivers to secure or dispense their opioids, and really be checking the PDMP screening methods, the pill counts, to identify any challenges or initiate discussion. When appropriate resources are available, you may consider a referral to a specialist. So recognize that the referral sources are short supply, especially in Utah. Really finding someone who specializes in addiction medicine, if you could, for certain situations, is great, but they're very limited, so we understand that. We do have some resources. We have a provider down where Norm practices and another provider up with Dr. Anderson's area there that we rely on, but they do get overwhelmed, with the amount of patients. So I think it's a part of medicine that I hope more people take interest in and can help support communities. So I thought this was a pretty interesting slide. This is a newer slide for this year. It really understands that we need to treat like any other chronic illness. That's chronic pain is like chronic illness. They're similar in so many ways. This compares actually the relapse rates between drug addiction and other chronic illnesses such as diabetes, hypertension, and asthma. I mean, these are biologically mediated. There's a psychological component like we've been talking about, socially mediated. So lifestyle changes can help. So a lot of the same things that drive some other things and also that we use to help try to keep people from having relapses apply to chronic pain, chronic opioid use disorder. So this is just medications for opioid use disorder. There's no recommended time period or period of treatment to reduce mortality. It's more important to individualize the treatment plan than to establish quote unquote best practices. Patients with opioid use disorder have decreased mortality. I'll just kind of read this because I'm going to come back to this a little bit later. Mortality when treated. In 2019, still only 13.4% of individuals with opioid use disorder received medication to treat that. Medication treatment with methadone, buprenorphine, or naltrexone is evidence-based. Relapse rates are in the 90% range over time in those patients with an opioid use disorder who decline medication help. Medication for opioid use disorder is associated with improved treatment retention, lower rates of opioid use, improved social functioning, decreased injection drug use, reduces risk of HIV, HCV transmission, and overall better quality of life. And anyone with a DEA license can prescribe buprenorphine. And buprenorphine itself was always able to be prescribed without an X waiver, just not is in the form of Suboxone originally, but now we're good. As far as methadone for opioid use disorder, it is accessed in federally regulated opioid treatment programs. And then naltrexone is an opioid antagonist, and it's approved for both opioid use disorder and alcoholism. It's effective in controlling cravings for opioids after a period of detoxification. Yes?
Question.
Yeah.
Are these, the treatment options, are the goal to put them on it and then taper them down or keep them on it?
Yeah, so we'll go through a specific one. I got some examples at the end of this about buprenorphine itself on ways to implement that. It's very generalized. There's a lot of nuance with it, but I think it's a good starting point. So you can kind of go through that. Yes?
I've heard that there's evidence for GLP-1s to decrease cravings since everybody's on GLP-1s now.
I'm not totally familiar, but I'm familiar that there is evidence. Yeah, but
They're doing some studies on that.
yeah, I don't want to go different there too, but there's a lot of things too with, I think, diet changes to naturally enhance GLP-1 itself that I think we're not kind of optimizing as well, but that's a totally different. I won't go there for this, but yeah. So it's also kind of with this whole bag here. What I like, getting back to naltrexone, what I really like is it's good for those cravings after, so it can help prevent that relapse patient. So important to keep that one in mind. And then it's a common misconception that we're merely substituting one drug or one addiction for another. That is a total misconception. I hate hearing that anywhere. We're not feeding an addiction. We're kind of treating an underlying disorder, just like we would hypertension or diabetes. So jumping into buprenorphine here. So buprenorphine does save lives. People with opioid use disorder are up to 50% less likely to die when they're being treated long-term with methadone or buprenorphine. And the quote from before, I found a CDC stat from 2022 that showed we are maybe making some headway. Only 25% of patients are offered medication specifically for opioid use disorder compared to that 13.4, so it's kind of trending in a good direction there. With buprenorphine, it does have a plateau effect for respiratory depression, so that's not only good efficacy and safety profile, but that's kind of the reason. But with that, with that, you still have to co-prescribe naloxone. So just be aware of that. For like buprenorphine itself, even if you're using Suboxone that has naloxone in it, it does not have an active form of naloxone in it. That it gets released if they misuse it. So if they like inject it or alter its form, but you should still prescribe even with Suboxone, naloxone too as well, just in case they have an overuse or event there. And then it treats withdrawal, cravings, overdose. It's safe and effective. It dissolves in the mouth. So make sure you take extra steps to help lessen the risk of dental issues or dental problems. So usually what I say is after they take the medication and it completely dissolves, just take a sip of water, kind of swish it around in the mouth and the gums, but make sure that they wait at least an hour before brushing their teeth, kind of to avoid damage to the teeth and the gums itself. So I'll go through this. I'm just going to pull up all of these at once. So basically, buprenorphine, we all kind of know this, it's a partial opioid agonist. It has a high affinity for the mu receptor and outcompetes other opioids while maintaining a ceiling effect on respiratory depression. As a partial agonist, buprenorphine has limited opioid effect, but it does have enough to stop withdrawal, but not enough to cause intense euphoria, and it does provide analgesia as well. And then this is just kind of a little quick summary, basically looking at microdosing. There's also what we call micro-inductions, but they're somewhat nuanced. They can be a good option for patients if they have chronic pain and opioid use disorder as well. There are multiple methods as well. People talk about the Bernice or the modified Bernice. So there are different ways to do it. There is an example towards the bottom here of kind of microdosing buprenorphine from the VA guidance on chronic pain itself. And then really the lowest effective dose of buprenorphine should be maintained. But should patients stabilize, right, before reaching the proposed kind of end doses, it's not necessary to proceed with further escalation of dose. And you also don't need to taper them off. These can be maintained. This can be maintained long term. Okay, so that's it for me on chapter 3. There was other information that I don't think made it on the slide. It was just updated information on the 2022 CDC guidelines. Just want to briefly talk about that, if that's okay. The scope, basically for those guidelines, we're all aware, they were adults 18 years and above. Outpatient with pain excludes sickle cell disease, cancer-related pain, palliative care, and end of life. These were revised guidelines that were expanded to also address acute and subacute, so less than a month, 1 to 3 months respectively. And the revised guidelines themselves include new evidence from systematic reviews showing non-opioid therapies to be at least as effective as opioid for many causes of acute pain, headaches, low back pain, neck pain, and other common musculoskeletal disorders. It really did also talk heavily about patient-centered decision-making, which is important. Shared decision-making is a crucial concept with the new revision, and that also we should use them as a means to apply evidence to our patient clinical discussions and to inform our clinical decision-making, not as a set rule that should be followed without consideration of our patient's unique characteristics in clinical presentation. So that's it for that. Okay. Yeah.
So, buprenorphine is a little more expensive than just opiates, and so I get that.
Yeah.
I can't afford it.
Yeah, and that's where I think go ahead, Norm, and then I'll finish. We're a little spoiled. Sometimes I call pharmacies, talk to the pharmacist, work on plans. There's different forms of buprenorphine, obviously, too, the patch, mucosal, sublingual, and we do have a clinical pharmacist within Intermountain that we can rely on. She sometimes will go through and look at the insurances, put together a list of cost effectiveness, but yes, there are situations where it may not be an option for some patients because of cost. But
And just to add, I will sometimes go on singlecare.com, BuzzRx, GoodRx, and compare the prices. And I've done that for patients and just printed out a coupon and say, hey, if you go to CVS, you can get it here for this. And that way,
the
it's made it a lot-
coupons, we've done
yeah.
that quite a bit for some patients. So, yeah. Yes, I can't. I'm surprised I think I didn't miss it, but I'm very surprised.
But it's used mostly for opioid withdrawal. But what if you have a patient that needs to be started on an opioid? Why
They do too. Definitely. And we have a lot of people too that come over from orthopedics that are kind of outside of their quote unquote window of, post-acute pain and that should be treated with opioids. We've done a fair share of transitioning some of those to buprenorphine products. Now, it may be different, right, where you're maintaining it long term. That's not necessarily the goal without opioid use disorder, but we have had good success with adequate pain control with buprenorphine for short periods of time. Just kind of finding the right combination, which product works best for the patient, which could be maintained, but we've done that quite commonly, more so than maybe not.
So I guess the patient I'm thinking about
Yeah.
specifically is the patient who says, I can't get to a surgeon until such and such a date.
Mm-hmm. Yes.
What can you do for me?
Yeah.
What kind of dosage would you start in that sort of a situation?
Always start start low and slow, and you can go up to based on what their needs are. As long as you have close monitoring, you will have to see them pretty frequently. Is what I would recommend. If we're doing this, we're seeing patients or having check-ins on a weekly basis, sometimes every 2 weeks, sometimes a few days when we start these products. But I've done that multiple times where we say, hey, there's buprenorphine product. Obviously, it's a little safer than other full agonist opioids. Better profile, could produce better pain management, especially someone who also maybe have a neuropathic component as well. Buprenorphine can be a little bit more efficacious for that pain generator. So we do that frequently.
Yeah, I mean, typically for something like that, I might consider a 5 microgram Butrans patch, or even Belbuca.
Belbuca,
the 75.
75 to start, yeah.
Starting once or twice a day.
And sometimes the patches for some patients just don't work as well. It's kind of a trial and error. But then you can there's ways to change over and stuff. So, yep.
One more last question.
Sure, no problem.
Is shared decision making. Well, with an opiate dependent person, they don't want to go on anything other than their opiates. So how do you convince them that they need to change?
So that's a tough, yeah. I mean, it can be, we've had some patients I've known for years, 2 years, and we've just maintained them on that medication safely, as safe as we can. And there's one visit that a year and 6 months later where we have a window or an opportunity where I'm interested in this, or we just kind of give them some information, or we circle back to it. And I don't think I've had a patient that I haven't at least had some window or multiple windows to talk about it and try it. And I've had patients that come in who've been on opioids for 20, 30 years and the same one with no issues. And we have to kind of talk about that. Thinking of one in particular that we were able to transition to buprenorphine. She's doing great on it. Yeah.
I've seen post-surgical patients come on a new pain medication,
Yeah, Jornavox. We can comment on it. I'm not sure it's part of the discussion, but yeah, we can definitely comment on it. I haven't had any personal experience with it. I was just at the American Academy of Pain Medicine, which is a great conference. It was actually here in Salt Lake, and it may be coming back in 2 years. So not that I have any affiliation, but a little plug. It was great, and they were speaking a lot about that medication from areas of the UC San Diego, UC Davis. I was able to talk to one of my mentors that's used it quite a bit, and has been having very good success. However, the coverage for it and getting it covered for a window of time where a patient comes in and says it worked great, but it's covered for that maybe 2 week window, 2 to 4 week window, and then kind of what do you do after that? So that's my anecdotal experience, not personal through me, but just talking to colleagues in at conferences.
I actually used it when I had shoulder surgery earlier this year.
There you go.
I found it very helpful, effective, maybe reducing about 30-40% of the pain. Usually start with a loading dose. I believe you'll take 2 50 milligram tablets the first night, and then do it for 1 2 weeks after. And then I just stopped it. There was no really withdrawal, no problems taking it. There is a risk, though, of kidney failure or kidney injury if you do it too long. And so typically, I mean, the recommended windows for doing it for a couple of weeks, you can get it.
Mm-hmm.
Now, like Select Health and others are covering it for up to 2 months. But when I'm doing with patients, I say, hey, look, this is a short term.
Yeah.
You can use it post-surgical, things like that.
And post-surgical, that's what my question to one of my mentors from UC Davis, who was using it quite a bit, and using it for not non-acute settings, like post-surgical settings. And I thought, well, how are you using this? He was using it a lot for what he thought was more an inflammatory mediated type pain, nociceptive pain, in someone who had chronic pain, let's just say chronic low back pain, but had an acute flare. So maybe someone that has discogenic, vertebrogenic mediated pain, facet mediated pain, where it's pretty much well managed throughout the year. They've done different procedures, radiofrequency ablations, but they have these just periodic flares once a year, twice a year, that usually last for a week or two. And he was using it in that specific population and was getting fairly good success. Just knowing that, hey, this is for this flare, this chronic underlying condition you have that is acutely flaring, using it for that, and then we're going to be coming off of it again. But for chronic, maybe peripheral central sensitized pain, might not be a really sustainable option. Anybody else have any? Okay. Well, we have another chapter. Okay. We may just get started soon, everybody. We got one more chapter here, and then we'll go through the questions after this, too.
Okay, and mine's not nearly as detailed or neuroscience-based as what Matt and Josh's was. I'm Stephen Anderson. I've been with Intermountain for about 2 years. I trained at Ohio State University and stayed on as faculty for a couple years before moving out here. My wife's from the area and wanted to move back closer to home. So we're going to talk about just almost, actual clinical application of what they talked about. And so typically the recommendation would be if you're going to start someone on opioid-based medications, start them on immediate release, not extended release medications. And as Josh said, typically the recommendation would be start low, go slow, right? And usually the recommendation would be considered a trial, just as if you were doing anything else, that this is a trial of medication. This is not a commitment to long-term prescription use. The hope would be that if there is a way to use other medications, such as Josh talked about, adjuncts to opioid-based medications or other interventions that we're able to use to help reduce the amount of opioids being used, that those things can help supplement that. On the chart on the right, it looks at, the 1 year and 3 year probability of continued opioid risk just based on the day's supply for the first prescription. And so you can see, obviously, the longer the prescription, the higher probability that they'll be on these opioids long term. There's always challenges with getting people back into clinic. I know, for example, if I inherit a patient or there's a patient that's referred specifically for that, we always have a very in-depth discussion. Everyone's practice is different, but I always go through the risks and benefits of this and let them know, hey, worst outcome here is addiction, which can ruin your life, or death from overdose, right? And I was talking with one of the physicians from Colorado, and I've had people say back to me, well, there are things worse than death. And I say, no, there's not, right? If you die, it's catastrophic for you and your family and everyone involved. And I understand sometimes it's, a little tongue-in-cheek for individuals that are in chronic pain, but we talk through that, and we talk through the risks and benefits and really make it a very in-depth discussion and an individual plan. I think the important thing to know as well, and this is always a challenge, is there is no obligation to start opioids for individuals. These patients can be very challenging, especially we have patients that are sometimes sent over where we know that they have had issues with heroin and cocaine and these substances in the past. And, I don't know if it's the right approach, but my approach is you will not get short-acting opioids. You will be placed either on buprenorphine or Suboxone or one of those medications in my clinic, or we can send you over to an addiction specialist. But that is not an option for those individuals, which is challenging. It is a very challenging conversation to have. And again, it's not always the right option, but it's just making sure that we're trying to do the right thing by these patients. And so, again, looking at it as a trial, starting out low dose, short prescriptions. Oftentimes, if I start someone on a medication, I will see them back in 2 weeks in Utah, and especially with Intermountain Select Health, we're very fortunate, I think, that we still can do a lot of telehealth visits. And so I oftentimes, if we're starting a new medication, such as an opioid, we will see them back pretty quick. And we will make sure, hey, there are no adverse effects from this, that we're not having, using more than what we're supposed to. We try and be very specific in the prescription and what we're telling patients and what is actually written on the bottle, so they know how often they are to use it, how much they are to use. Overdose and risk of adverse events is highest in the first 90 days for a new prescription of medications. And so it's just trying to do your due diligence to, again, make sure that we're helping. Most often, There have been a few exceptions to this, but most often the recommendation would be to obtain a urine drug test prior to prescribing opioids. I do that for nearly all of my patients just to make sure there are not any aberrancies, or that you then gave a prescription that comes back a couple days later and surprise, surprise, there's cocaine in the system, or there's something else that you were not told was there. And so that way you can make sure that it's consistent with what you expect and what's prescribed. And then they talk about the guidelines, I think, for following up with urine drug tests and the different types. I think Utah is at least once a year, just depending on the patient and the risk, you can do that more often. In my clinic, if patients do have aberrancies, it's not a hard stop, like I'm cutting you off. It is, let's have a conversation. Let's figure out how to work with you, because I think, again, that is the right thing for these patients. I don't think it's, if I cut them off and say, I'm not treating you anymore, they're going to end up in another clinic, and it's now someone else's problem, and I don't think that's the right thing. As a physician, is trying to be conscientious with these medications, and I don't think that's the right thing for the patient. And so oftentimes those patients, I will see them more often until things are consistent. We will order more urine drug tests, which does come with an added expense for the patients, which it is a challenge, but it's trying to do the right thing for them. And so, follow state guidelines on that, and if things are consistent and they're stable, there's not necessarily a hard and fast rule, but oftentimes every 6 months or every 12 months is reasonable. Depending on the amount of opioids, it may be more often than that. You can do screening tests in the office. They're oftentimes cheaper. You can get an immediate result in there, and that oftentimes will give you a class of medication, not necessarily specifics. Oftentimes, so for example, I don't know what you guys have in Salt Lake or up in Park City. I don't have access to screening office-based tests. We have to send people over to the lab. So again, it is a little bit more expensive. It does take a little bit longer to get back, but typically we can get those back within several days. And so if I see someone for a new consultation, or it is an initiation of opioids, I just let them know, hey, once we get these results back, I'll review them. We'll give you a call and we'll let you know if things are okay, and we'll go from there. You can get very specifics into the confirmatory test, and so you have a high sensitivity and specificity for those tests, looking specifically at not just the class of drug, but individual drugs and metabolites. Most medications, most substances, whether it's illicit or prescribed, will show up in your system within several hours. Medications that are typically lipid soluble or lipophilic will stay in your system for longer periods of time. Certain medications are out of your system. And so it's important to know, when did they last take the medication? Is this a continued medication? Is this more of an intermittent medication? The concern is, if they are prescribed a medication and it doesn't show up, is there diversion going on? Are they selling these medications? So again, I think on an individual basis, having a good relationship with the patient, doing appropriate pill counts when they come in and looking at that oftentimes helps clarify that. I don't know if it was the last slide or the next one, but they talk about a positive test and a negative test, and not calling it a dirty test or something like that. So if the medication shows up, it is positive. If it's not there, it's negative. There is a lot of cross reactivity. I remember in one of the textbooks we had during our pain fellowship, it gave this whole list of all these medications that could show a false positive on these tests. And so I think that is something to be aware of. That does happen from time to time. And if that's the case, I think it's prudent to repeat the testing and just, again, continue to work with the patient, make sure that this is not a false positive. This truly, was an aberrancy, or is this, another substance that you have to continue to work with them on. Examples of metabolites that you can get in medication. So if people are taking codeine, they may show up that they're positive for morphine or hydrocodone as well. About 10% of folks that are on morphine may test positive for hydromorphone. And folks that are on oxycodone can test positive for oxymorphone. And I think oxymorphone is one of those ones that was prescribed frequently years ago, and occasionally you run into it anymore, but it's typically just not a common prescription. So a lot of times these are metabolites that do show up on these lab tests as well. Again, I think kind of what's been reiterated a couple times, talking to patients and just having conversations. Part of our medical management agreement that we go through with patients in our clinic is, we talk about, what medication might be considered, why it's considered, what other options exist besides opioid-based medications. The importance of only filling at appropriate intervals, to not call in, to not use more medication than prescribed, to not call in for early prescriptions, because we will not send them. If you lose your medications, you got to keep track of these things. They are controlled substances. If you have children in the home, or if you have other individuals in the home that may be able to access these things, keep them in a safe place, and keep them in a place that would not cause someone else to accidentally get into these. Typically, we have everyone, at least in my clinic, who is on any sort of opioid-based medication, sign a medication management agreement. And I think the important thing to note with that, at least in my practice, is, if someone goes in for a surgery, you can still treat their surgical pain, right? You can still treat their acute pain. That is absolutely fine. It's more the chronic condition, that we will manage that. And so, if patients, a lot of times they'll panic if they go see a dentist or they have a carpal tunnel release or something, they're given a short course that, I violated my medication management agreement, I'm going to be cut off. And that's not the case at all. We expect other clinicians to also treat their pain. We're just also there to help for the baseline pain. So, and there are a lot of good examples online that you can find of medication management agreements, or you can use AI to help formulate these things and have these forms. There are a lot of good things. I don't know if any of you have ever used Open Evidence. It's an AI specifically for medicine. It's phenomenal. You can find all sorts of literature. It's partnered with the New England Journal of Medicine, and I think JAMA, I have no affiliation with it. I just use it from time to time, and they do a really good job of helping with evidence-based practice and best guidelines, but also for forms and also for appeals for denials for insurance. So I've used that a few times for those things. And again, shared decision-making, I think, is an important thing. Just having conversations with people and helping understand what are their goals. It's not just to reduce a number from 10 to 5. It's functionality, it's quality of life. It's all of the things that, actually make up good quality for these people so they can have meaningful lives and continue with that. And so, not just with the opioid medications, but are they willing to explore other modalities? So most of us are interventional. We do a lot of, minimally invasive injections to even surgical procedures to help with chronic pain. And I think it's important to help people, understand what the role of these things are, but I'm not pushy on any of that. I'm not pushy on medications. I'm not pushy on interventions. Certain people don't want injections, and that's okay. Certain people don't want medications, and that's okay. And so it's trying to find the balance that help these individuals meet their goals, so that shared decision-making. And then always looking at, what is the underlying source of pain? Can we find that? Are we able to identify it? And sometimes we're not. Sometimes it's more complex than, it's an old injury or it's a disc herniation or something like that. And then continually monitoring that risk for opioid use disorder. And we'll talk about that a little bit more about tolerance dependence and things like that. If you do decide to taper individuals off of opioid medications, typically the recommendation would be to continue to follow with these patients even after they're off, because there is a high risk of relapse, either getting prescriptions from other physicians or even obtaining substances from the street. And so the general guidelines is follow them for about 2 years and just make sure that things are okay. There aren't hard and fast rules for how to wean people off of opioids. It can be done slowly. Every couple of weeks, it can be done a little bit more quickly. And I think really, again, that's an individual basis, just looking at the duration and the oral morphine equivalents that they're on, and then just working with the patients to do that. And that may require more frequent follow-up. So, and it's the same thing with folks with opioid use disorder. Sometimes people fall off the wagon and then they get back on, right? And so it's just continuing to work with these individuals. If they are physically dependent on opioids, there are medications that can help assist that. And so it's using all the adjuncts that can be done, or the partial agonists that Josh talked about, the buprenorphines. There are specialists in the area. So Dr. Hellowell is our addiction specialist at the Layton Clinic, and then there is one in Provo, I believe it is. And so they work with those patients specifically for those reasons, and they're a good resource to have. There are the CDC has good examples of how to taper off medications, but again, these are guidelines, and so it's an individual thing. I think this is an important thing to talk about as well, how to dispose of unused opioids. There are good websites. If you get on, I was on Google before this and I looked this up, so from where we are right now, there are 17 locations where you can take your medications, your controlled substances, to dispose of them, including the police department, the sheriff department, McCady's outpatient pharmacy. So within a 9-mile radius, there are 17 locations where you can actually take these medications to be disposed of properly. There are some that the FDA says you can flush down the toilet. They talk about, in-home options. You can throw them away after mixing them with kitty litter. I would encourage you not to encourage patients to do that. I think there is enough availability at pharmacies for people to be able to dispose of that. And a lot of clinics, even the family medicine clinics in the area. So for example, in our clinic, we were able to obtain those packets that you can pour into the prescription, put water in, and it will dissolve the medication and make it an inert substance. And so there are a lot of good ways to do that rather than just saying, I dumped it in my kitty litter and threw it out with the trash, right? For me, that's always did you, or is this a diversion thing, right? Did you use more than what you were supposed to, or what's going on here? So I think there are better options than recommending to do that. And I don't know if you guys see that ever, but I had a couple patients that said that, and I said, let's not do that next time, please. The question always then becomes, extended release formulations of medications, long-acting opioid medications. So again, the recommendation would typically be start with an immediate release and start slow, low dose, and reevaluate. the idea behind extended release medication is really to increase the steady state. So the medication is in your system more. So Josh talked about disruptions to sleep on these short-acting medications. You look at some of these formulations, for example, oxycodone, it can take 30 to 60 minutes to really get in your system. It may last 3 to 6 hours depending on how you metabolize it. And so you may only stay in your system for 3 hours, may stay in for 6 plus. And so sometimes these extended release formulations can be very beneficial. Again, I would advise caution with these. There are appropriate uses of these, but I think in some instances, there is higher risk, like OxyContin, as we all know, that was actually a very potently addictive medication, and it was undersold as that. And so I just think with some of these extended release formulations, it does require a little bit more prudence. They do have other formulations than pill forms, such as the patches that they've talked about, which I think can be very helpful for people. And so it's just, again, looking at what are the goals here, what's the doses of the medication, and then just having a conversation with patients. And again, it's a case-by-case basis. There's not a hard and fast rule there to say, hey, we're going to convert from immediate release to extended release. I tend to be very, very cautious and hesitant to do that with individuals. And again, it requires frequent follow-up. Typically, the recommendation would be not to start an opioid-naive patient on an extended release medication. And I think even if you look at fentanyl patches, that's actually one of the contraindications if they're opioid-naive, not to start with a fentanyl patch for someone like that. Now, there may be exceptions like cancer-related pain or things like that, but again, there's other specialists or areas where they can address that. Typically, I would say that the extended release formulations are more expensive. They, again, I think we're fortunate at Intermountain to have some clinical pharmacists that can help us with some of that, finding costs. But that is, I think, an issue with that. Sometimes adherence to the immediate release medications can also help trigger that. I think is where they talk about it. Yeah, so any strength of transdermal fentanyl patch, they typically don't recommend starting that in an opioid-naive individual. And they still do make, extended release morphine. They still do make extended release oxycodone. Xtampza is one of the abuse deterrent formulations of that, but there's no generic for that, and it is an expensive medication. Typically, they recommend if you are transitioning to an extended release formulation to really pay close attention, especially in the first several days, because that is when the risk of overdose is the highest for those individuals. So again, I wish there was better guidance on that, and I wish I could tell you, hey, definitively do this every time, but there's not. It's a case-by-case basis. And you could probably make the argument, if you're at that point where you're saying, you know what, like maybe I do need to, we're considering this, it may not be a bad idea to refer them over to a pain management clinic for that discussion, and if they get transitioned and things are stable, take back over at that point, just depending on what's available in the area. And that's, again, not a hard and fast rule, but it might be prudent to do that. The FDA did add a warning to opioid medications in 2023 saying that, hey, if you're on high doses of medications, it could actually cause increased pain. And that's more of a psychologic phenomenon that can happen with that. I've seen that in my own practice, both in Ohio and here in Utah. And so that's typically individuals that are above 90 oral morphine equivalents. And so you increase medications, pain increases despite that. And so that's where, again, we would typically look at doing other things besides just increased medications, whether it's adjuncts to that, non-interventional, non-medication-based modalities and therapies, other interventions that may be helpful for that. So it's just paying attention to that. They do talk about opioid tolerance and dependence, and I think it's worth noting with this, it's not on the slides, but I don't know if they talked about this in fellowship with you, but they still taught pseudo-addiction, and that was something that was coined in the late 80s, I think when I was 5 years old, so well before I even thought about doing anything like this. And the idea was, well, people are coming in and they're needing more medication, they're not really addicted, it's a pseudo-addiction. There's maybe some tolerance there, and so you just keep jumping up that amount of medication. And again, I think it's just being cautious with that. People can develop tolerance where they're on a medication long enough, and that medication does seem to be less effective over time. And so we'll talk through some strategies to how to mitigate that. So typically, patients that are on 60 milligrams of oral morphine a day, or 30 of oxycodone, these doses are considered likely to be tolerant to these medications. There's a difference between tolerance, physical dependence, and addiction. So tolerance, again, you're on these medications, they may feel less effective with time and require escalating doses. Physical dependence is where, if patients stop these medications, they will have withdrawal side effects from that. So their body needs the medication, which again is not necessarily addiction. They're not, demonstrating these addictive qualities or behaviors but their body does become dependent on these medications at this point. So these are physiologic adaptations to being on these medications long term. And so again, not necessarily the same thing as addiction or opioid use disorder, which was, I think, a question that was asked earlier. One of the things that you can find if patients do have tolerance to medication is sometimes rotating to a different medication. That can be beneficial. So if someone's been on oral morphine for a long time and they find that it's just not as effective, you can rotate to a different formulation. So, and again, there's not a hard and fast rule to say, hey, if you're on morphine, rotate to oxycodone. If you're on oxycodone, rotate to hydrocodone. It's just having a conversation with, I think, a patient and also having close follow-up to say, did that help? So we talk a little bit about how to do this. One of the things that you have to watch for is as you are rotating from one medication to another is to watch for some of these adverse events to make sure we're not having increased respiratory sedation, especially in overdose. There are a lot of tables that you can find online. So MedCalc has a really good, online website. CDC has good guidelines for looking at the equivalencies of these medications, and we'll talk through that here in a second. So, for example, if you're, taking oral morphine, IV morphine is about 3 times more potent than oral morphine. Oxycodone is about 1.5 times. Oral oxycodone is about 1.5 times more potent than oral morphine. Hydromorphone, if you look at the IV to the oral form, it's about 5 times more potent using the IV versus the oral, and the oral hydromorphone is about 4 times more potent than oral morphine, right? And so, there's a lot of good calculators online if you do have questions about that, where you can find those resources both through the CDC and then also a lot of academic centers have these as well. So, let's see. Typically, the recommendation would be that if you're going to rotate from one medication to another, that you embark on at least a 25% reduction, sometimes 50%, depending on factors such as age, the amount of medication, and how long they've been on the medication. So, for example, and this talks through some examples of that. So, for example, if someone was on 30 milligrams of oral morphine and they were taking that 6 times a day, that's 180 milligrams in a 24-hour period. So if you wanted to rotate them to an equivalent of 20 milligrams of oxycodone, so that's a 1.5 difference, so that's an equivalent dosing, how would you want to reduce that? So there's your conversion factor, you solve for X, right? And so you'd end up being an equivalent dose of oxycodone to morphine would be 120 milligrams, which would equal that 180 milligrams that they were on. And then you would reduce that by 25 or 50%, just depending on the patient. And so again, that's a case-by-case basis, just depending on how long they've been on that and when you can see them back and things like that. A lot of times, that is very effective. Sometimes people will find that a new medication is not as effective. So I think if you are doing that, it is worthwhile having very close follow-up with these patients. Yeah, so then your new dose would be a 60 to 90 milligram dose. Sometimes people fixate on the numbers and they think, wow, 60 is way less than 180 or 90 is way less than 180. And so it's just having these conversations that it's not necessarily a one-to-one equivalency here and why we're doing that. And I've rarely had pushback on that from folks to say, hey, we're going to rotate for these reasons. Here's why we're doing what we're doing. And they say, oh, that makes sense. So if you're switching to methadone, typically, again, they don't recommend giving this for opioid naive patients. I have never done this. I don't prescribe methadone. You see it from time to time, so that's not one that I'm super familiar with. But typically, they would recommend that if you are tolerant to it, not to exceed 30 to 40 milligrams upon rotation, so whatever the dose is. And I think it might be on a further slide, another one, they usually recommend if you're rotating to methadone to reduce that by up to 75 to 90%, so it's a big drop in the methadone. And then if you're switching to buprenorphine, you can cross-taper with buccal films or transdermal patches. Josh talked about this a little bit. You can do microinductions with that so people can stay on their pain medication, and you can actually start low-dose Suboxone and increase that slowly and then wean down on the opioid medication as you continue to increase the Suboxone as well. And there are very good guidelines on that that you can find online. If patients have breakthrough pain on extended release medications, typically the recommendation would be to use an immediate release medication at about 5 to 15%, somewhere in that range of what their total medications are. So for example, if they're coming in for a procedure or if they're having surgery, we talked about other things like Dornavix, which might be a good idea for a lot of these individuals. I typically don't prescribe immediate release and extended release medications. I have a couple folks I've inherited on both, and again, they're stable, and their counts are always consistent, and they're not showing any signs of tolerance or dependence or addiction. And so there are some exceptions to that, but I personally try to avoid that as much as possible. I think that would be a prudent thing. That's CDC does not typically recommend having people on both, but if you do have breakthrough pain, typically about 5 to 15% is what the guidelines are. Typically, and they recommend not using extended release formulations for breakthrough pain. They, again, do have abuse deterrent formulations. So, the patch formulations, Butrans is the patch formulation of buprenorphine. It's usually good for 7 days. It is not cheap. A lot of insurances don't pick it up, and I think the cheapest I found it through GoodRx was about $60-something for individuals. But for certain individuals, $60 a month is a big deal. That's not an affordable thing, so that is a challenge with that. Again, Xtampza is an extended release abuse deterrent form of extended release oxycodone. It's expensive. There is no generic formulation for that. And so a lot of times these things can be helpful. It doesn't mean that they 100% cannot be abused. People can find ways to abuse all sorts of things. And so, but they are more difficult to abuse. So there are options out there, but a lot of times there is still a challenge for these patients to access these medications. So, yeah, and then the question comes up when to refer to a specialist. And so, I think definitively, if you look at your questions, right, if they need specialized interventions such as a pain pump, that's when to refer over. I think if you're in those areas where you say, like we're talking about transitioning, I'm not quite comfortable. I think there are a lot of good, pain physicians in the area if you're in this area or in a lot of areas that are willing to help out with that. And so I think at any point, if you just take a step back and say, what's the right thing for the patient? Do I feel comfortable doing this and managing this, or am I a little bit out of my depth here and need some additional help? Probably not a bad idea to do that. Or if you're looking for adjuncts to pain medications that they're stable, and we say, hey, are there interventions that we might do, such as, intrathecal drug delivery systems or, epidurals or things like that, that'd be a good time to do that. An addiction specialist, again, if a patient reports that they have a history of substance use disorder or that they are developing addiction or demonstrating these addictive behaviors, I think that's a good time to refer over to that. Or again, if you feel that this has kind of gone beyond my level of feeling like I can manage this appropriately, that's what those clinics are for specifically. So probably worth taking a picture. There are, good resources, again, in the area, at least throughout Intermountain and here in Utah. University of Utah has good resources as well for individuals that help with these things. So. Oh, go back. Oh, I'm sorry. I went too fast.
Thank you.
Yes. Any questions on any of that? So nothing hard and fast. Again, I think the take-home point from that section is just if there is consideration for starting an opioid medication, it needs to be an in-depth conversation, and I would argue probably a very specific visit for that reason, not at the end of a wellness check or something like that, but that's what you're seeing them for, that, having them get a urine drug test prior to starting that, having them sign a medication management agreement if that's something you're going to undertake with them, and then routine follow-up and close follow-up, and then starting low-dose medication, starting slow, and then just continual follow-up until you're at kind of what that target goal is.
Quick question.
Yeah.
I work with a lot of youth, like, at a university.
Uh-huh.
And we do exactly what you say, like, we test, we haven't signed a contract and everything per DEA. But the sticky part comes when you're doing the urine test and it comes positive, like the latest one was cocaine. And so, he didn't want to repeat it. He said he'd come back, and he came back in 3 days and asked us to repeat it, but we felt like it'd be out of his system. So he had a cow and reported us for being incompetent and blah, blah, blah. So what would you have done in that thing?
So the question was, for those on the video, if you have individuals that come in and, you're following these guidelines, you're getting urine drug tests and something pops up positive like cocaine in the system, and then you bring them back and they come back after it's probably out of their system and then they don't want to repeat it, or they report you. One, I don't care if people want to report me for that. You're doing what's appropriate, I think, in that case. And typically what I've done, I've had a few individuals that's happened. You're coming in every 2 weeks and you're going to get urine drug screens consistently until we can prove that you're clean. And if we feel like there is, you're kind of figured out the system and you're skirting that and saying, hey, I'm using cocaine on these days and not the days around when I know I have to come in, I will call you in for randoms. I typically try not to do that for individuals because I think it is very burdensome for an individual to be called and say, you've got 24 hours to be here to get this test, or else people have work and families they have to take care of. But that would be an exception, and just say, hey, this is how we practice. These are the guidelines. If you can't follow that, then we cannot continue to prescribe for you.
We go
So,
over the contract very careful with
Sure.
them, and if they agree to
Sure.
be randomly tested, well, it was of a different culture or ethnicity.
sure.
So he reported us to Title IX for refusing to serve him
Yeah.
in his way.
Nope, and I think if you're following guidelines, I think you're fine. Those are challenging cases, and I think those are certainly individuals that can become very verbally or even physically aggressive, and so you have to be very cautious with that. But I think you did the right thing. I think you guys can chime in if you want, but I would have done the same thing. I would review the medication management agreement with them, review what they agreed to when they first said that, and said, here's how we practice. If you're not willing to abide by that, we can no longer prescribe these medications for you. And typically, most individuals are agreeable to that, but you do have a few exceptions where they just, are not going to, unfortunately. So,
And one thing that was developed at the the Utah Valley Clinic and was implemented there, and kind of taking it over too with randoms. Drug screens, you call them and I'm busy, I can't come in. They've created a little paperwork that they fill out at the beginning that the patient's required to list during the week, like their work week, certain times when they would be available, usually consistently. So they put the list down, the patient signs the form, it's signed, dated, so that when they do call them, they call them on those times that were individualized for the patient. So when the excuse comes up, hey, I can't, then that's kind of a little bit of a red flag in itself too. And it's just another way of documenting to protect yourself too.
yeah, and I think, and those are, I think you have to have like appropriate clinical staff and resources to be able to do things like that. So like in my clinic, it's myself and 2 medical assistants, and those become very challenging to do that because we're kind of, and so I think those are, like, if you have the support system to do things like that, it's awesome. Like and again, just documentation. So we were talking earlier with another physician, if we embark on dose escalation of medications, I document it every time and document the rationale for why we're doing that. Or if we decrease medications or rotate medications, it's always documented. So that way, again, if someone else, if they transfer care or go somewhere else, it's in my notes, it's in my records, and those are things that we just pull for every time. So sometimes it can get a little clunky in the notes, but the rationale and the thought process is there. And so there's another question.
Two situations actually. So my partner's out of town. I'm covering for him. Patient comes in. He has more than what I'm comfortable with on opioids. So
Sure.
pretty high morphine equivalent dose that he's on. So my standard approach is to say I am uncomfortable with this.
Yeah.
I will be willing to prescribe a lower amount of this. You will need to make this order until my partner gets back in.
Yeah.
And they always show up 2 or 3 days short of that. I ran out.
Sure.
And then I'm stuck in that whole cycle.
Sure.
So how to handle that? And then the second question is when your patient wants a prescription to Walmart, how do you handle that?
Like a printed prescription? So there were 2 questions there.
Kind of
Any prescription?
to Walmart, because they will rewrite if you write for anything more than 3 days.
Oh, yeah. So the 2 questions were, if I'm covering for my partner and they're out of town and a patient comes in who is on an amount of medication that I'm not comfortable prescribing for, how do you handle that? And the second question was if you send a prescription over to Walmart that they will not, what was it?
So Walmart will not fill a prescription for more than actually I think it's 2 days.
2 days. So Walmart will not fill for more than 2 to 3 days. Do you guys want to answer first? I can chime in. It's a challenging question. I mean, I think it just depends on your comfort level, and I think, best practice would probably be that, as if your partner is having these patients on opioids, have that conversation that there may be times when I'm out of town, my partners are covering, they may not be comfortable prescribing this amount of medication, so the patient is aware. I think that's a challenging situation. I think if you have access to an Utah PDMP or DOPL and you're able to review that and things are consistent, you can review partner notes that, counts have been consistent, urine drug screens have been consistent. Personally, I probably would just write the prescription and make sure they have appropriate follow-up and just reiterate that point. But I can't dictate how you practice, and so I fully understand that. So I think that's a challenging, unique situation. oftentimes if you send over a prescription and patients are running out a few days before, they're probably using just the equivalency of what they had before. And so if the maths, then I don't know. There's not a straight answer there. Norm, do you have something to add to that?
No, just great point. Sometimes I'll actually do shorter prescriptions.
Yeah.
And maybe a 1 week, maybe a 2 week, and say, hey, this is what we're going to do if I do this. And if a patient starts coming up short, that is generally, or if I suspect that possibility, doing a shorter prescription will kind of force them a little bit more to be a little more cautious.
And I do, that's a good point. And I do have individuals, and this is, again, kind of burdensome for patients, but I have individuals that have proven that they cannot get more than a week's supply of medication at a time because they will burn through it. And we see them monthly, and they get 4 1-week prescriptions at the pharmacy, and they have to pick it up every Monday or every Wednesday. I typically prescribe 7 days at a time, or even, if it's a month supply, I do 28 days, so it's every 4th week on a Wednesday or a Friday, so that you're not getting these weird 30-day Sunday to Tuesday hopping around. It is every 4 weeks, what day that prescription's at the pharmacy, and you have to keep your appointments. And so that, I think the shorter prescription might be a good option for that.
We had talked about too, this is just a lot of how much does this chew into your day and how can you make this work with your schedule? That's really what it comes down to. There's so many different ways to, do everything. So, the extreme side, if you had all the time in the world, there's a lot of things, possibly considerations. We don't do random counts. We do pill counts at every visit. The patient knows that, hey, when they come in, they're bringing in their medication and we're kind of counting it. I have some patients, like I was mentioning earlier, that print out monthly calendars and they write down how they take it each month. They're proud of it to show me, hey, I'm taking this much, that much. It's individualized a little bit, but when you have those counts too, it also empowers patients. They can figure out how they're taking it. Most people who come in to see us from other places, we ask, how are you using them? They're like, I'm not sure. I just take what I need each day. And I'm like, is that 3? Is that 2? And they really can't answer it. As we start doing some counts of medications each visit, they start feeling more empowered. Hey, I thought I was using 5, and in the last week I maybe used 3 or 4. Hey, there's, do you need that many? Could we reduce? I never thought of that before. I guess it looks like I can. So there's ways to do that. It does chew some time up to do that count each time, but we have some of our MAs do it just quickly on a form. It's a few minutes, if that, to do that. And then basically you can also formulate prescriptions from them to protect you. There's ways to do fill dates and start dates for pharmacists. And I've actually talked to a lot of pharmacies and they appreciate that. So sometimes we'll kind of give a prescription with a fill date, an earliest fill date. This is a date when it should be available to be picked up. Now that doesn't happen all the time with pharmacies, right? They call and they didn't have it available, but sometimes we'll set that fill date as the day before. So, if a patient is out of medication on a Tuesday, we'll have the fill date as a Monday, so they don't feel pressured to, I'm out and I have to get to the pharmacy and start it. What if my car doesn't work? I get a flat tire. Like, it's available, but they have the understanding to know, because it's in my note, when the start date is. And the start date is based on the previous count and how you're utilizing the medication. So again, these are just examples to the extremes of stuff of how to do this, but it's kind of thinking through and trying to implement some aspects into your own practice as best you can, and you're just doing as best you can. That's really it, and trying to keep them safe and protected and educated. And as long as you're doing that and documenting that, then I think you're well ahead of the curve.
One of the things, the Walmart thing, I guess I was just thinking about, I had this happen yesterday where we were rotating to a different medication with a patient. They still had some of their original prescription left. But because we saw them yesterday, we said, hey, let's go ahead and do this. And if we end up not using the old prescription, we'll dispose of it safely. And it's someone that I've worked with for a while and I feel I can trust. I will put a note in the pharmacy, hey, UDS is appropriate. Doppel is appropriate, seen this day, plan follow-up this day, we are doing this, and I'll have my MAs call the pharmacy and actually speak to the pharmacist when I get a chance. And so I think that's, rather than saying, hey, we're gonna send it to CVS or Walgreens, that can flag them as saying, why are we going to multiple pharmacies here? I think if you speak to the pharmacy team and say, hey, my partner's out of town, we're sending over this prescription for this much, I am covering for him, we are in the same clinic. I've never had pushback from a pharmacy team for that. And so I think if you are able to communicate with the pharmacy, that may help. Again, that may be at the pharmacist's discretion as well, but I've had pretty good results with that too. So I don't know if you've done that before, or if you've gotten pushback from the pharmacist specifically for that reason, but.
Well, I always get a call back from Walmart. It's universal.
Yeah.
And it's no, we will not fill this prescription. Please write it for this lower amount.
Yeah.
It's like, because you saw the patient?
Sure. Yeah. Yeah. And that's something, and we've had that happen time to time. And so a lot of times, like in those cases, like just anticipating that may happen, like if my medical assistant team calls over and I speak, physician to pharmacist directly, like I usually they say, okay, this makes sense. I understand why you're doing what you're doing. You're in the same practice with, Dr. Minori, and you're covering for him because he's physically out of town and can't send that prescription. We're willing to do that for this amount of time until they're back in the office. And so,
And sometimes that fill start date is already filled in. Other times I just put a sentence in, and then each time the prescription's renewed, the sentence is there already, and I change the date based on it. So once you just get into a groove, however that works for you, it's kind of can be quick.
Well, honestly, I'm surprised you guys aren't seeming to have the same problem. Maybe
Yeah.
it's me that's being flagged.
no, I don't know.
I did have that happen with a morphine patient. As many of you know, morphine's a couple manufacturers have stopped manufacturing that. And so for some patients, it is getting harder. I did have a patient who came on a big dose. We've been slowly tapering and working. And a pharmacy came back and said, hey, we're not going to cover it at that dose. So I called the patient and said, look, this is the situation. And I used it as an opportunity to further taper down just a little bit more and say, this is where we're going to go. And the prescriptions, so if you worry about that possibility, again, the short prescriptions are usually what has helped me and helped them to stay more in check with that.
Again, sorry, I wish we had a hard and fast, hey, do this. But a lot of times it is just so nuanced in those cases. So, yeah. But that is, and I don't know if you guys do this, but every time I send an opioid prescription over, if patients have been on these for years, I will comment. There's a comment to the pharmacy, at least in the Epic system we have, or I sent her before, and I will say, a medication MMA is in place, UDS is appropriate, Doppel reviewed this day, seen this day, plan follow-up this day. So at least, and those notes make it to the pharmacist most of the time, and so at least they know, hey, we are continuing to follow up these patients, and it's not just, why are they sending these medications over and over and again? And when I've talked to a couple of the pharmacists for other reasons, they say, hey, we've noticed these comments, we appreciate that because we know, what you're doing and when the follow-up is, and that, it kind of hears why you're doing these things. So, yeah. Good question. Any other questions or thoughts?
As a retired anesthesiologist, I've seen this pendulum swing back and forth in both directions.
Yes.
For a long time. When I started out, before you were born,
Yes.
and she said you weren't born in the 80s.
No, I was born in the 80s, but I was 5 when that statement came out in 1989. So
Well,
I was,
before you were
yes.
At the time, when I was rotating on the pain clinic as a resident, the rule was we never treat chronic pain with opioids.
Yep.
That was a hard, fast rule. When someone came into the inpatient clinic, first thing we did was detox them off of their opioids, and then we treat them some other way. Well, then the pendulum started to swing the other way, saying that having your pain treated is a civil right.
Sure.
And that's when the pain scale came out on 1 to 10. How do you, and then the comedians started saying, say 8, say 8.
Yep.
If you say 11, they think you're a drug addict. If you say 1, they won't give you anything.
Yeah.
So supposed to just, everybody said 8 if they wanted opioids. But then there was a feeling for a while there when OxyContin came out that some patients with chronic pain, you have to treat it like hypertension. They're going to need to take opioids the rest of their life in order to be functional. Sounded kind of reasonable at the time, but because of that, so many patients got addicted to OxyContin that now the pendulum has swung in the other direction where it's like pulling teeth to get one Lortab out of the ER.
Sure.
So where's the right place for the pendulum to land? And it sounds like you're treating a lot of patients with chronic opioids, from what I'm hearing. Patients are taking them kind of like antihypertensives.
Sure. Yeah, and it's a good question. And I think when I was going through fellowship, and it's probably a little bit right after Matt and Josh, but, it almost pendulum had swung over to you like, we're purely interventional. We're not doing any medication management. So we're only going to inject everything, which is also not the correct answer. You could put a spinal cord stimulator in everybody in this room, and a lot of them, it wouldn't work. Or it'd work for 12 months, and then the body would adapt, and you find that they become less efficacious with time. And so I don't know what the answer is. It's somewhere in the middle, clearly. But yeah, there are still, and I think at least, with Intermountain, most of the patients that I have that have been on chronic opioids, I've inherited. I think that I've had very few that we've started on medications, because if they're already not on there, it's just having those hard conversations to say, this is not the right thing. I do have certain individuals, and a lot of times it's individuals that are, older, or it's almost more of like a palliative treatment, not that they're imminently dying, but almost, what's the goal versus if you're 20 years old, very different situation, right? So
If you're 98, give them whatever they want.
I have a 94-year-old Marine Corps veteran who, he started on other things, and we've got him on a pretty hefty dose of fentanyl patch, and you know what? He's functional and he's stable. And we see him every month, and his wife keeps an eye on him. And we've never had problems, but he's doing the things he wants to do at 94. What's the end goal there, right? Like, well, I don't want to say death, but at some point it's imminent that it's coming, and so that's very different than if it's a 25, 35, 42-year-old, right? And so,
going back, I think you made a good point. A lot of it, the pendulum has started to swing. I found that there is a sort of some middle ground there. I found a number of patients, though, we'll talk to them and say, hey, you may do better on lower doses or even do better off. And I've about 80% of patients, I've had a number of patients slowly taper off. Have one right now. We did a spinal cord stimulator. He was very skeptical. He started getting about 50, 60% pain. And immediately he went from, he came to us on a very high dose. He reduced down from 240 down to 120, now going down to 90. The fact that it really motivated him, and he noted, hey, I've cut it in half. My pain's not really any worse, hardly. And that motivated him to keep going. And a lot of the patients, wherever they're at, a number, almost all of them, I would say 80, 90, who've come completely off and allowed some of that hyperalgesia effect that opioids often provide. And I'll tell patients this, and you start allowing your natural indigenous opioids to start functioning again, they will find their pain's not any worse. In many cases, it's better. And a lot of them feel like, hey, you know what? I can function on this. But it does take time. It does take repeated conversations. And as they start to go down on lower doses and they start to say, hey, I'm doing okay. And then you're that coach. You're that one who's kind of helping to guide them to say, well, you don't have to come, what can we do with this? How can we work together on meeting your goals with this? But I found a lot of it's middle ground. I do have an elderly patient, a broken rod in her back, and she's doing well with about, I think 10 milligrams a day and allowing her to function. And we've allowed that, but she's actually tapered from where she was and is functioning better at a lower dose.
And I don't know exact numbers on that. As a pain management physician, I would probably say most of my patients are not on chronic opioids, or some that have chronic prescriptions use it intermittently still. So it's not, 4 to 6 times a day at high doses, and we use other things that are helpful. And, I think looking at the overall lecture and the presentation, it's using that multidisciplinary approach and helping people understand there's not one size fits all, but that there are resources out there that can help them improve and help them have better quality of life and function with that. So it's a very good thought. Any other questions?
Yeah, I think everybody did a great job, and I just think it's really about just setting up expectations, whatever that is, whatever you decide your kind of protocols can be. I mean, in a perfect world with all the resources, it's everything. I think there are certain aspects you have to do, and then everything on top is just icing on the cake in a way. But it's just kind of developing what that protocol is and telling the patients what your expectations are of them, and it's their decision to fall in line with that or seek care elsewhere that falls in line with what they want for themselves better. So I think as long as you can be honest with a patient like that, they understand that, and they're usually okay with that.
Not that I'm aware of in the law, if there's any obligation that, I mean, yeah, I would go through, you know, again, review the medication management agreement, say that is part of it, is if you have to take your medications prescribed, you can't lose them, and we've had patients do that, and, just say like, unfortunately, we don't send for lost prescriptions, you are responsible for those medications. It's a tool, you know, just like if you had a firearm in the home, you need to make sure that's in a safe place, it's a tool, and so they have to be responsible for those things. So no, there is not an obligation in that case, and in fact, I would call that a violation of your medication management agreement, and you kind of have to determine on your own, like, how many stripes patients you're getting, and just have those hard conversations with them, and just say, look, like, this is the 10th time this has happened, you know, unfortunately, because of that, we can no longer prescribe for you. You know, and again, you're not trying to create further problems for other individuals, I think, it's just that is part of what their agreement was with you and your practice in your clinic, and if they're not willing to abide by that, unfortunately, you know, I don't think that's an obligation
So
you
if
have.
they go out and like shoot up on heroin and they die, are you liable?
I mean, if someone has a drinking, gets in a car and crashes, are you
Yeah,
responsible,
I know,
right? So
I
no, I think individuals also have to accept some sort of responsibility in this and understand, right? So,
If you've got it all
Yeah.
documented.
And the pitfalls, I think, come with documentation. So we can talk, we have templates set up that cover everything. So for me, it's a few minutes to check through these things. They remain in every note. They're updated every note. There's never a note where it's like, hey, you just copied and pasted that. It's every note updated, tracks of variances, the dates, the counts, the fill, the start. And as long as you kind of develop that you're comfortable with, to whatever extreme you're comfortable with, and that patient knows those expectations,
I think you're doing the right thing in that case by the patient and trying to be as responsible with them as they can, but ultimately, at the end of the day, they also have agency and they have to make those correct choices, right? So,
You know,
which is hard. It's not an easy answer. You don't want bad outcomes for individuals, and I get that.
Yeah, I actually had a patient who came to us, I don't know, but they said their family was allowing them to take 15 pills of fentanyl per day. They wanted to get on a short acting and whatever. And, you know, we just put the notes down and had a hard to fast conversation. I drew a picture of them and said, this is you 6 feet underground. Sooner or later, that drug dealer of yours, that friend of yours, doesn't care. He likes your money, but he doesn't care about you. And I begged him, you know, I said, I will do a Suboxone induction right now. But we've got to save your life and we've got to help you out. Now, unfortunately, in this case, and I did everything I physically, mentally could, except I almost wanted to pin him down, but he actually walked out and said, I'm sorry. You know, he wanted more of that short acting. He wanted more of that high. And I did everything I could to beg for his life to say, but sooner or later, you will die if you continue down this route. That risk is way too high. And at the time he didn't. Hopefully, you know, he checks himself in sooner or later. But as you mentioned, you try to do everything you can. If you start to also see someone making short missing counts, or maybe they're a few pills off, buprenorphine is a good conversation to have. Buprenorphine is a great conversation to have, even in chronic or other pain situations. It's a great medication if you feel like, you know, to have those conversations with certain patients, populations.
So has I've seen everybody looking down at the paper and filling it out. I'm sure everybody's had a chance to do the test. We can just review it together if you'd like. Kind of done this in the past just as a group, so if you feel like you want to shout it out, go ahead. So we'll just, with number 1 there, anybody, the senses from the crowd? So C, yep. So for number 1, the correct answer is C, synthetic opioids. And we can talk further after too to clarify anything as well. How about number 2? A is correct, yes. And number 3? B is correct, nociplastic pain. And then number 4, you know, so number 4, B is in boy, opioids for nociplastic pain is incorrectly matched. We talked about fibromyalgia patients and those kind of complicated pain patients. And how about number 5? A is correct, yes. Number 6? C, respiratory depression for this. And number 7? B, yeah, yep, call 911 if not already done. And we'll go to number 8, A, buprenorphine. And number 9, D, yeah, discard in household trash. Good. And then number 10, C. Yes, consider for like a pain pump, intrathecal pump. Okay. So we just real quick, 1 was C, 2A, 3B, 4B, 5A, 6C, 7B, 8A, 9D, and 10C. And if there's any questions on any of those, please come up and ask us. We'll talk through them. I think just make sure you have this paper filled out if you have this all from the class here. And then they'll take those, they'll collect those in the back there for the credit. And then if there are people I think are at home listening in, they can follow the link and send it in, and then we'll confirm that hereafter as well. But I think that wraps everything up. So thanks for hanging out for a long time. This is a long lecture. Appreciate everybody's patience and the great questions from everyone. So thank you so much.